about 15-20 years before, that it will let us understand about the phenotype-genotype correlation. Till now, genetics is good for diagnosis, good for some patients who are heterozygous states, we have to sort it out, or for screening in some patient group. Phenotype-genotype correlation has not happened, and still in a subset of patients we don't find any mutations. So whether there is another gene or intron related issues, or there are epigenetic factors which is responsible for manifestation, needs to be explored. This has been, this is in one of our study along with ISC, we did genetics in a DBT funded study, 102 families, and we found 36 different mutations, and a lot of novel mutations, about 13 or so we found out. And this is a chart where there were studies from Chandigarh, Kolkata, Vellore, Lucknow group, and kind of observations are same across the various studies in our country, or where some of the mutations are more common in our country compared to the West. Now getting to the electrophysiology, you can generally these patients don't have clinically overt autonomic dysfunction, but you can find out by doing bedside autonomic function test, or by cardiac involvement in ECG, or by doing evoked potential. They will not manifest, but you can find subclinical abnormality. And to the extent that I did, because we have MEG, so we did MEG also in that somatosensory evoked field or the visual evoked field or the auditory evoked field localized the same, but compared to the control group, there was differences which is difficult to clinically make meaning out of that, but there were observations were there. Coming to the most important, the radiology, we know CT scan sometimes helps, and we see hypodensity in the putamen. The MRI is most useful and helpful for the diagnosis. Quite often we have not suspected, and after seeing the MRI we go back and ask for the copper specific tests or KF ring, and one is, you all know, the thalami, the putamen. Then some patients do have extensive white matter, then midbrain tectal plate changes is very important. Rarely diffuse atrophy, the frontal gliosis, even cerebellar atrophy, especially in those who have severe tremor, can be seen. Then the specific ones are, this is the face of giant panda, this is central pontine myelinolysis like sign, this is bright claustrum, this is T1 hyperintensity, especially in those with a liver which is still ongoing, is bad. So these are the various studies in the MRI observations, and kind of matches with the last one being ours, and matches with the studies done outside, that the dominant changes are in the basal ganglia and brainstem. You should remember that the central core, the basal ganglia and the brainstem, subset will have white matter changes. So this was one study about we described the Mercedes-Benz sign, the three kinds of central pontine myelinolysis. One is the whole one, then the bifid one, and this you can see that spared one looks like a Mercedes-Benz, so which we described this one. So does MRI help us to differentiate with extrapyramidal, other extrapyramidal disease? And this was done by Prashant when he was with us, and it does help to differentiate with other. And what are the main thing which does help is face of giant panda, tectal plate, CPM, combined putamen and brainstem, combined thalamic and brainstem, and combined basal ganglia and brainstem. These were all differentiating points favoring more Wilsons than others. Does treatment help and MRI changes improve? Yes, it does that. In serial MRI of 50 patients when we studied, which was published in VJR, that in 35 there was improvement in MRI parameter, no significant change in about 10, worsening in 4, and admixture of some patients, some places it worsened, some places it improved. The spectroscopy are on all indirect. It does help to understand the undergoing biochemical problem of those neurons or the white matter. Now going with the development, well, MRI like the DTI metrics are of the white matter, yes, compared to the control it's different, it is altered, and in a even subclinical patient or mild symptomatic patients also it was abnormal. And with treatment these DTI metrics also may improve, which another resident Anish, he did it. So coming to the therapeutic part of it, these are several problems which all of us face, zinc, penicillamine or both. I'll try to briefly touch on each. Penicillamine induced worsening, other side effects, non-availability, zinc induced vomiting, hematology, dose of zinc, etc. So the treatment obviously is a counseling because lifelong treatment. Copper free diet is a issue in our country, especially in those families who have been eating non-vegetarian foods and copper rich diet. So it's very difficult because mothers will, our textbooks are Western textbooks, and there I'll spend a little more time because I think it's important, and the non-vegetarians are cooked in a discrete way, not curry based. Ours is curry based, so everything goes in the curry. So mother will give curry and potato, not the piece. So that is useless. So we should insist that don't cook at home. Egg you can eat, and other copper rich like nuts or chocolates. Another interesting in our routine colloquial, we say any sugar candies as chocolates, especially in rural community. So the dietitian told don't give chocolates. Poor fellow, he did not eat sugar candy, and 2 years later he asked me, can I eat this one? He got in his pocket. So we should be very, very clear that chocolate means that real chocolate. The dietitians also needs education. For penicillamine, we need to have start low and go slow, to the extent that suppose you see a very severe patient with lot of signal changes in the MRI, don't start on penicillamine on day 1. It is what I generally do is start on zinc, stabilize the patient. After 2 to 4 weeks, start preferably alternate day. Give for a month alternate day, nothing will happen. If you see in these 2 months patient has not worsened, then make it daily, and then after that a month later twice daily. So slowly built up. Slow means that slow. What generally slow means, after a week make it 2, and the third week make it 3 days. Don't do that. And zinc, majority of the textbook will say 150 elemental zinc. So all our capsules or tablets will have 50 per tablet, so 3 per day. But you know, all this our genetic problem is going on. So we probably discovered that even if you give 6, nothing happens. Maybe our content is less, so which is difficult to advise. Now, when we give as a neurologist, the patient may worsen, patient may remain same. This is the majority. They will partially improve or completely improve. Generally, you will see about 60, 70, 80% improvement if the person is very compliant, has come in time, you have given that correct treatment. Majority will have somewhere in between complete improvement to partial improvement. Now, when we give penicillamine, it should be alone, empty stomach, 30 minutes before meal, and zinc, always zinc should be before feed, and penicillamine should be after. The gap between penicillamine and zinc should be 2 to 4 hours. So practically 4 hours is not possible because for the night time. So it's better that they have little early dinner, and 2 hours is a good time. So suppose 7:30 they take dinner, so 7 o'clock they take the zinc and take about 9:30 or so the penicillamine, and then go for bed. And in pregnancy, whatever our limited experience, it may not be contraindicated. And another like penicillamine induced worsening, here I will again spend some time. This graph all of you see, this is a patient has come to you, and you have somewhere started here the penicillamine. What will happen if you take by natural, you know by natural course patient is worsening at some speed. You have started penicillamine, after that also majority patients will recruit some symptom at the same pace. The majority of the physicians or people who are not aware will tell this recruitment of symptom at the same pace as penicillamine induced worsening. No, it is not. Penicillamine takes some time, few weeks to few months, so for the symptoms to decrease. Only this, if you see sudden rise, that out of proportion to the natural history graph, you know that yes, this was his progression, then only it's penicillamine induced worsening. It may be out of 10 patients, 1 or 2, 8 or 9 will be here, this kind. Zinc is very helpful, and it is very good for maintenance. You can use anything between 150 to 300. One thing new I have acquired in last 10 years of zinc, that very high dose zinc in a proportion of the patients may cause hematological problem, that is low counts because of bone marrow suppression. And so this without any symptoms of any other toxicity signs. So if you change, decrease the dose, that helps. A subset of patients has very bad vomiting moment they take zinc. So what generally in that situation can be done is, you can change the salt, like suppose patient is on sulfate, so you can go to acetate. So trying to change the salt, sometimes just changing for some weeks, when the patient is taking daily half an hour, so they may not be taking half an hour, they may be taking like a diabetes pill, take the medicine and start eating. So really mother should be instructed, give 1 hour before the food. So these small changes may help. Triantine, we are lucky that it's available in our country now. It's still very costly, and in patients where penicillamine has caused problems, we can try it out. Tetramab molybdate is indicated. It's not FDA approved, but Brewer has pushed for it, and can be used, but it's not available in our country. So both, the Americans prefer the penicillamine, don't prefer penicillamine, and since Walsh is from Cambridge, he had pushed for penicillamine. So there are no randomized control trial as to which we should do, and our center we use both. Over a period of time, I realized that it may not be 10%, it may be much lesser, the real penicillamine induced worsening. So patients who have clinically very severe and MRI showing very severe both gray and white signal changes, go slow. Stabilize with zinc, start alternate day, then once, then twice. That will help in vast majority of the patients. So sometimes differential improvement with neurological, this is one forced, so about 20 years before, unfortunately the administration had problems with money, so they stopped penicillamine. So substantial number of patients, penicillamine they could not purchase. So luckily we had documentation of the scales and good follow-up, we gave only zinc. So zinc only was sufficient in helpful in maintaining. So I had a paper out of it that no problem, they stopped the treatment, but we can still show that yes, zinc alone is useful as a maintenance. Liver transplantation is good for pediatric liver, bad liver, and in neurology not much. It has rarely been used for intractable, and even in systemic disease, this is a last one as a systemic review. Liver transplantation is promising method of Wilson disease management in patients of severe neurological, if the patient has not responded to pharmacological decoupling, but those with having concomitant severe liver disease, it's definitely indicated. Symptomatic drug treatment, we all give trihexyphenidyl, we all give clonazepam. It will not touch the patients. The degree of improvement will be generally less than 10%. But we have no choice. We are seeing a severe dystonia, severe tremor, so we continue. So Inderal you may prefer where there is a large amplitude tremor along with portal hypertension. So propranolol, that in that sitting you can. This is one patient who had thalamotomy, very severe tremor. So Professor Pal helped us, and this was published in Movement Disorder. So you can see that this is the pre-thalamotomy tremor. This is the typical bat wing tremor. So this is immediately in the post-op ward. still diagnostic error is a problem in Wilson disease, and there are several causes for that. When we analyze that, one is low community, so people see less. Diverse manifestations are there, so versus expecting typical features. Low indices of suspicion, looking for family history of inherited or similar diseases we miss out. Failure to detect K-free by good ophthalmologists. Absence of clinical markers at initial manifestation, attributing extrapyramidal symptoms, especially in those with psychiatrists managing a behavioral disorder, to the adverse drug events. Misinterpretation of the lab reports and inability of appreciate the limitation of the diagnostic tests. So, once you have clinical suspicion, we should have confirmatory workup, and by and large we are lucky that we are seeing the patient when liver has already been involved. So, K-free almost always is there to help us to diagnose. So, proper slit lamp examination, a low ceruloplasmin helps. In a subset of patients, yes, where you have a diagnostic doubt, patient not following the usual your experience wise or the textbook lab problem, genetics you can do. And MRI is helpful for diagnostic, for prognostication, and in follow up hematology is a big problem. And just last words about that, I didn't tell that quite often in follow up we will see low counts being a problem, and as usual what happens that the blame goes to penicillamine, and often it's not the penicillamine, it's the disease per se, but we have no choice that when you encounter this kind of problem, stop penicillamine, do a count, low count, stop penicillamine, and do after 2 to 4 weeks repeat count. That will still be low, and most likely it is because of hypersplenism and not because of penicillamine. So that's one scenario. Second scenario, too much of zinc. So you can reduce the zinc dose from 6 per day to 3 per day, that may help. Third scenario is disease per se. So there good compliance, if the patient has a compliance issue, follow up nicely. One hematologist from St. John's, where we refer regularly, Professor Cecil Rose, he used to give short course of steroid like ITP patients 2 to 4 weeks, and in some patients I have seen that the counts come back. So this is the way maybe you can manage when this is an issue. I think, thank you very much for your patient hearing.
Thank you, sir. Now I would like to request Dr. Dinesh Choksi sir to join the chair. Please,
sir. Thank you very much, sir, for the nice and wonderful comprehensive coverage of the Wilson disease, and especially thanks for giving practical points for the management of Wilson's disease. For the next talk, I would like to invite Dr. Tarun Nagpal sir. He is from Jabalpur, and he is going to present today his talk on rapid onset dystonia with Parkinsonism. We have already listened sir yesterday, and he presented talk on neurotransmitters in sleep. So welcome, sir. Rapid onset dystonia with Parkinsonism. Meanwhile, any questions for Wilson's disease? We are going to start next.
Good afternoon, everyone. So, this is going to be a case. Dr. Sanjay Sharma wanted this meeting to be very, very clinical. So, he told me that bring a case, no lectures. So, this is a case which I want to present. So, in neurology, especially in movement disorders, I feel clinical phenomenology rules. This is a 20-year-old gentleman who came with acute speech and swallowing difficulty. And there was some posturing of hands. He had difficulty in holding the cup and manipulating his buttons of his shirt. He had mild difficulty in walking with slight flinging, which developed over 1 or 2 weeks. And after the initial progression, he remained static. He went on to ask the family history, but unfortunately, both his parents had succumbed in a motor vehicle accident of 4 years ago, and they were unaffected by that at that time. He has an elder brother. In fact, the elder brother used to get him to the clinic, who was unaffected. He had no perinatal birth problems. There was no history of trauma, seizure, meningoencephalitis, stroke, or intoxication. And there was no preceding illness or a drug like levosulpride, which people use. Nowadays, we find levosulpride is the cause of 50% of the movement disorders. He had a mass facies, looked Parkinsonian. Speech was markedly affected, and he was anarthric. Very difficult for him to speak. He had difficulty in swallowing. He had bradykinesia and mild gait difficulty. Reflexes were mildly brisk, plantars or flexors. So these are his videos. So he is talking. So if you can see, he is Parkinsonian, and since the audio is not there, I'll tell you that he had difficulty in speaking, and he was anarthric. This is how he uses his upper limb. He is able to use it, but he complains that it is not so easy for him to button or unbutton the shirts. And this is how he walks. So walk is fairly preserved. So anarthria, upper limb involvement, and lower limb involvement. Investigations, we found a ESR of 15, looking for neuroacanthocytosis. There was no neuroacanthocytes. His blood glucose, serum calcium, metabolic parameters were normal. We know Wilson's disease is a great masquerader. The test was negative, and MRI brain was normal. And since he was Parkinsonian and he was dystonic, we tried using medication without any benefit. So we have, in summary, this 20-year-old gentleman who presented over 2 weeks with dystonia and Parkinsonian features, and then remaining static. So he came after a year, he was static. 15 days progression, no further increase. And there's a striking craniocaudal gradient of affection. Severe anarthria, severe difficulty in swallowing, some affection of the upper limb, but walks nearly okay. So we did a genetic study on him, and we found that this was a defect in the ATP1A3 gene. And so the diagnosis was rapid onset Parkinsonism dystonia with this heterozygous mutation. Now what does this gene do? This gene encodes a alpha-3 subunit in the sodium potassium ATPase pump. So the pump is used for the health of the neurons, and so this gene encodes a part, and since this is defective, sodium potassium ATPase pump fails. And we know that this single gene does not cause only rapid onset dystonia Parkinson, but it can also cause various other phenotypic manifestations like alternating hemiplegia of the childhood, the Kappa syndrome, early infantile epileptic encephalopathy, and the Reka syndrome. So a single gene can cause multiple phenotypes. And now it is known as like a spectrum. So you can have different features occurring as a spectrum with overlap in some of these. So it's a rare autosomal dominant movement disorder with a variable expressivity, reduced penetrance that is caused by this mutation, and it is located on chromosome 19. So what is the take-home message? Could we have diagnosed this clinically? If you see, here's classical features. Abrupt onset, then there is a static phase, and then this affection, which is craniocaudal way of affection. However, there can be some supporting diagnosis, there is no tremor at onset. So these patients have Parkinsonism, but mostly rigid. They are not tremulous. And sometimes they can have second onsets. That means there is an abrupt worsening later in life. So they remain static, and then they can worsen also. So this is the first case of genetically proven rapid onset dystonia Parkinson case from India, which we have not published. I searched the literature, there were cases of Kapos, but we have not published. So most important message to my younger colleagues, apart from this, pay attention to the phenotype is, keep an eye for the unusual presentations, keep your data, attend scientific meetings, and find time to publish. Because I am sure this is literature lying with me for the last 3 years. Someone may have by this time from NIMHANS or AIMS published this. So as a clinician, the mistakes which we make is we keep our cases, we see the cases, we make a diagnosis, and then we forget it till the time patient comes next time, ask, kaise ho? Waisa hi ho. Bye. That should not happen with the younger generation, and we should correct it. Thank you so much.
Thank you, sir, for this nice case. And for the next talk, we have some change in the movement disorder talk of the today's talk. And I would like to invite Dr. Bindu Menon ma'am for the next talk for the neurological complications of pregnancy. We have preponed this talk, and this was scheduled on 27th, but for some reason, we have preponed it. Ma'am is from Tirupati. Welcome, ma'am.
I'm from Nellore.
Sorry, ma'am.
That's okay.
Sorry.
It's just nearby. Thank you very much, sir, for inviting me for this wonderful meeting and for the excellent hospitality as well. This is a very large topic, but I'll just try to cover up some aspects of the neurological complications that occur in pregnancy. So when we look at neurological disorders which can happen in obstetrics and gynec, we know that there are certain biological differences between men and women which contribute to many sex-specific illnesses and disorders. And historically, it was argued that such differences were largely, if not exclusively, due to gonadal hormone. So there are certain general issues in the women because of the sex differences in the regional brain structures and the functions. Then there are certain life stages and neurological diseases that happen, particularly in girls, adolescent age, during the cycles, during the pregnancy, during the postpartum period, and in the menopausal changes as well. Then there are certain neurological disorders in women that inherently happen. What are the special concerns? There's some 20% of women suffer from migraines, we all know that. Sleep disorders in women are often overlooked. There is a hormonal change which makes them predisposed to seizures, and with the seizure frequency increasing to around 30%. We know that universally it has been found that MS is more prevalent in women than men. Medications have a significant impact when we look at pregnancy and the contraceptive effectiveness. There are a lot of jugglery which we need to do during those times. We know that stroke mortality is also higher in women, and there are 30% of women who are unaware of the stroke risk factors. That's a big burden of the disease as well. Other concerns are the disease could be a first presentation of a non-pregnancy related disorders. There are several symptoms we know that which could happen in pregnancy, like dizziness, pains, headaches, which are very common and very difficult for us to treat and investigate because of the concerns of various test related factors which we have. Or it could be a new onset disorder predominantly occurring in the pregnancy or postpartum, or the patient could be having a pre-existing disorder. Let us say the patient has a migraine and now comes with a status migrainosus and comes with this migraine with aura. So I'm not sure in that emergency department how aggressive I should be, whether I should treat it as a pre-existing disorder which has increased, or whether she has developed a new illness like a press. So I don't know what I should do, and especially if it's a nightmare when you get a call and when you are at home, you have not seen the patient and you don't know what to take a decision at that point. So there are several adaptations. There are physical and hormonal changes which predispose to a new onset neurological illness. There is an unpredictable metabolism of drugs. There is an increase in cardiac output by 25 to 50%. The blood pressure continues to remain low till the third trimester because of the lower systemic vascular resistance. And the BP further reduces in lying position and during epidural anesthesia. And it is very important that we realize these adaptations that happen in a pregnant woman, because this will help us in the treatment of the stroke and the eclampsia and in that particular lady. Now there are several hematological factors which make pregnancy a hypercoagulable state, that is an increase in coagulation factors, reduction in those prothrombotic agents and the procoagulant changes, and which normalize at around 3 weeks postpartum in that particular lady. So now let us look at a case. Now we have a patient who is a 30-year-old pregnant female at 10 weeks of gestational age and presents to the emergency department with a headache. Past history has been nil significant in her. She has a left-sided headache. She is lightheaded. She complains of dizziness. She also complains of blurred vision and numbness and weakness of her right arm. But 1 hour later, she completely recovers of all the symptoms. Now, in a particular individual, any other patient, we have those symptom list and we have a differential diagnosis and we can easily push her off to an MRI. But we can all understand that a particular patient like this comes into the emergency department. It is very difficult for us to convince sometimes some families of an MRI. We might be convinced. We also know that the amount of radiation that may go to the fetal is less as far as the head MRI is concerned, and it increases in proportion as you go to the thorax and particularly as a abdominal MRI. So what are the thoughts that pass into your mind when a person like this comes and who has a complete recovery? So our objective is that we should not rule out, we should always be wary of a ominous secondary cause. We should not be missing out a treatable secondary cause which can be threatening to the life itself. Simple thing, first, clinical, as we heard from the previous speaker, that one should always be clinically sound so that we do not miss out anything. So blood pressure, we know that this particular symptomatology what has been presented could be a presentation of accelerated hypertension as a pre-eclampsia in that particular patient. It could be like a press-like syndrome, but what is not very classical of a press is very focal sort of symptom and sign in that particular patient. Complete neurological examination with a cranial nerve, which we should look at a fundus for the patient and should look for a cranial nerve involvement, let us say for a 6th cranial nerve, which will tell us that whether there is a sign of a raised ICT in that and a gait assessment for that particular. And then we have the secondary causes where we should not be missing out. Primary, as I said, we don't know whether it was a habitual migraine with a complicated migraine at this particular patient at this point, because we know that there has been so many adaptations that has happened, or the ominous causes like IIH, press, pre-eclampsia, CVT, stroke, pituitary related reasons, and then the other ones. So the common ones first, we know that pituitary apoplexy can be a life-threatening disorder. This can present as a thunderbolt headache with nausea, vomiting and meningisms and visual disturbances with restricted field and ophthalmoplegia depending upon the extent of the bleed into the pituitary. So they can be just subtle symptoms with just blurring of vision but no visual field cuts. The patient can stabilize in the headache part as well. That's why the subclinical forms are also common. The hormonal insufficiency in apoplexy is a medical emergency, and the compression of the cavernous sinus content and the optic nerve. We know that MRI is a modality of investigation, and a proper MRI with the pituitary and sella cuts. Treatment with IV fluids and corticosteroids. In rare cases, one might need a surgery as well. So we have two pictures in the particular patient. The upper picture is suggestive of a bleed into the in a macroadenoma. The patient already had a pituitary lesion but was not symptomatic for it. But during the pregnancy, the patient bled into the macroadenoma. And we also have a picture here which shows that the patient had just a homogeneous signal intensity which is in an enlarged pituitary. But there is no pituitary apoplexy as well. So if there is no pituitary apoplexy but there is only an enlargement, the patient can present with symptoms, but then it does not become a medical emergency. We might not be wanting to treat, we just need to follow up. We have yet another patient, a 30-year-old with a second post-op LSCS who developed cough fever, treated with antibiotics. She became afebrile. 15 days later, she has a severe holocranial headache. Her past has infrequent non-specific headache again. Her BP and general examination is normal. She has papilledema. And her MRV is normal. So now we look into something where we do not have a vascular etiology for that, which is very common as a CVT, but then what one should not be missing out is that a patient, a good look onto the optic nerve is very important. Before we really go and do a CSF tapping and trying to find out the pressure, it is very important. We know that now there are MRI signs which should not be missed out, but will be missed out if we do not take the proper optic nerve cuts. That is the flattening of the globe, the Torch's optic nerve, the stenosis of the transverse sinus, the bilateral or unilateral. So we should not be missed out, which could tell us that yes, this patient is IH and I need to do a CSF, otherwise this patient did that. So if we want to go, if it is an isolated headache or treat, and before, if it is a headache plus seizures with visual symptoms as an altered consciousness, then we have certain differentials. If it is just an isolated headache and does not have any other features, if the patient has a typical prepartum, then we go and treat it as preeclampsia. So we need to be clear what are the very common things that happen in a patient, pregnant lady with a headache. One is an IIH that can happen with a pre-existing little headaches which she had. It could be an exacerbation of migraine. It could be a pituitary and a hormonal related event. It could be a CVT. It could be a stroke as well in this, or it could be a hypertension related illness in that particular patient. Now we come to another lady, is a 28-year-old, 7th and 10th day postpartum with severe occipital headaches. Blood pressure is slightly on the higher side. We know that her earlier baseline blood pressure was only around 120/70. CNS biochemistry, everything is normal. Occasionally a blood pressure surges, then she has seizures and hemiparesis, and her MRA and MRV is this. You can see that she has an acute, she has got multiple infarcts, bilateral, cerebellar, that is anterior circulation and the posterior circulation. And if you could just see that there she has got beading of the vessels of the anterior circulation as well. They were very subtle in the beginning to have seen that there is a beading, but when we look back from after she developed this further symptoms, then the subtle beading was also quite obvious to us. So unless you feel that there could be a condition called a postpartum angiopathy and can lead to an RCVS, you would not be looking for a beaded in that particular patient, especially in a night when you are sent that as images on WhatsApp and you just quickly look into it and your radiologist also quickly learns. So you see that the continuation of her scans, you can see that initially there was a beading, then the beading disappeared, and then her latest scans show that complete disappearance of MCA, and she was a classical case of RCVS, and she did improve, but she had later deficits as well. Now RCVS can present with a plethora of symptoms, and that's what we have reported, that this patient, particular patient, if you could see that patient has got an atypical press, it's in the mid pons, it's in the bilateral basal ganglia, asymmetrical. If you would see in the later scans, you can see the bleed there. If you will see that last but one, there is a subarachnoid hemorrhage as well. And there is a beaded appearance of the vessels as well. The patient completely recovered, though she had everything on that form. It can present with everything. You need to see every aspect on the scan, because if you have done that, and you could see that the patient completely normalized, and she had 3 out of the 5 criteria for an RCVS. That's a postpartum angiopathy. That's a rare form, but then we are most often very commonly seeing it more and more probably because we are seeing women in the later ages of life getting more pregnant, so they have an atherosclerotic component to them as well, and the presentation again is with headache and focal deficits. So that's how you differentiate between RCVS and PRESS. There is a headache here. PRESS also has headache, but the character of the headache is very thunderclap in RCVS. That's one of the differential of a subarachnoid hemorrhage or a pituitary apoplexy or an RCVS or a CVT in that numbering. And in a PRESS, you would see more of a vasogenic edema with seizures and visual disturbances. And the imaging findings, we know that there is a vascular imaging finding which tends to normalize with treatment or over a period of time. In some cases, it can be catastrophic as well. I suppose that's the time, and I think I'll take a call. Thank you so much. Thank you. Thank you so much.
Thank you. Thank you, ma'am, for enlightening us and for covering such an interesting cases of neurological disorder in pregnancy in a very nice way. Our next speaker is Dr. Anjali Chokse. She will talk on clinical approach to dystonia and myoclonus.
Excuse me. So good afternoon, all of you. First of all, I would like to thank Dr. Sanjay sir for giving me this opportunity. So I'll be discussing a clinical approach to dystonia myoclonus, which is a case-based. So my patient was a 42-year-old lady who presented to us with a complaint of abnormal involuntary jerky movements involving both her upper limbs and face, which started at the age of around 10 years. These symptoms were gradually progressive, and when she came to us, she also had some posturing of hand with mild backward pulling of the neck and the upper part of the trunk. These movements were very slowly progressive over 25 to 30 years. It was not associated with any gait difficulty, any swallowing or chewing difficulty. There was no features of Parkinsonism. She doesn't have any cognitive decline or psychiatric manifestations. And she doesn't have any visual symptoms or any sleep disturbance. So this is the video of the patient. So here you can see there is an abnormal posturing of her left more than right hand. She had tilting to the left side with the backward pulling of the neck, and she had these involuntary movements which were present at rest, and also you can appreciate the abnormal movement in her face also. So as she is raising her hand, these movements are becoming more prominent, and these movements are quite jerky associated with the posturing. It is present in both the sides but more marked on the left side. In the face, you can see the jerks are present involving her perioral area. She doesn't have any other associated comorbidities. The family history was negative. She was born of a non-consanguineous marriage. Her birth and developmental history was normal, and she has studied till 12th standard. She's a married housewife with 2 normal kids. On examination, as I told, she had myoclonus with dystonic posturing. The dystonia was involving her limbs, trunk, and the neck. And her fundus was normal, extraocular movements were normal. Other motor system examination revealed increased tone in all her limbs. The power was 5/5 and reflexes were brisk. We did the routine investigations including the ceruloplasmin, ferritin, alpha-fetoprotein, lactate, all were normal. So after the clinical evaluation and examination, we thought it is a dystonia myoclonus because the most prominent movement in her is dystonia and myoclonus. So if you see the criteria, it includes the major, minor and exclusionary criteria. So among major criteria, she was fulfilling all the criteria except she also had truncal dystonia, which is not there in a typical case of a myoclonus dystonia. And she also doesn't have a positive family history because SGC mutation is a autosomal dominantly inherited disorder, but she doesn't have any family history. If you see the minor criteria, the presence of psychiatric symptoms is quite compulsory in a case of SGC mutation, but she doesn't have any obvious psychiatric manifestation. And exclusionary criteria include MRI brain. So we did the MRI, and to our surprise, it revealed iron deposition in her brain. So initially we were considering DYT11, that is SGC mutation, but MRI made us confused, and we started thinking in the lines of NBIA. Because the normal, the SGC mutation patient should have a normal brain MRI. So now the competition was between SGCE and NBIA, and both had their sets of negative point in her. Like for SGCE, she doesn't have any family history, no psychiatric manifestation, involvement of the trunk, and abnormal MRI. But for NBIAs, there were some points which are going against NBIA, like there was no oromandibular dystonia. Although she had this myoclonus involving the face, but there was no oromandibular dystonia. Progression was quite slow, like till 45 years of age, she was mobile, doing her activities. She's mother of 2 babies, and she was able to do all her responsibilities. There was no ocular abnormalities. The cognition was normal. Then we started looking for the other causes of the dystonia myoclonus, and we developed how to approach these cases, because nowadays a lot of genes are coming which can manifest as a dystonia myoclonus. So if you see a case of a childhood onset dystonia myoclonus, they can have acquired or genetic causes. Among acquired causes, the common ones are the infection, autoimmune, and the metabolic causes. Among genetic, the 4 most important causes are SGC, as you can see. But when the SGC mutation is negative, then you start looking for the other symptoms, because SGC have only dystonia and myoclonus, but you get some other features, then you can look for the other genes. Apart from dystonia myoclonus, if the patient is having dystonia, chorea or ataxia and additional features, then you should look for other causes. Like if MRI finding is suggestive of some hyper or hypointensities, then you should think of Wilson's or PANG2 Platougics mutation. So we did the genetic testing in her, and it was positive for DYT11, that is SGCE mutation, which was our first differential in her. So if you see dystonia myoclonus syndrome, the myoclonic jerks in SGCE are brief, lightning-like movements, often involving the neck, trunk, upper limb, and less often involves the leg. And they are not stimulus sensitive because these are subcortical type of myoclonus. And these myoclonus are often present at rest, but mild but gets aggravated by the action. If you see dystonia in these cases, it is usually mild to moderate, and it is non-disabling, and usually spares the face, larynx, and trunk. The most common form of dystonia seen in these patients are cervical dystonia and writer's cramp. And it can involve the lower limb, especially in the cases who have infantile onset. Although the dystonia in these patients doesn't worsen or generalize in the course of the disease, and usually remains stable. But some atypical features which are seen in our case is the mild truncal dystonia and facial myoclonus, no family history, absence of any psychiatric manifestation, and MRI abnormalities. If you see the treatment response in these cases, it is usually symptomatic, and often the response to the oral medication is incomplete. Recent study shows that jonissamide may have some improvement, may cause some improvement in the myoclonus and the associated disability in SGC mutation. Other drugs that are usually tried in these cases include benzodiazepine, anticholinergics, dopaminergic agents, but all of them cause often incomplete response. And pallidal DBS is said to be an effective and well-tolerated therapeutic options for these patients. So it's always beneficial to do the genetic testing in these cases, because in intractable cases you can consider them for the DBS. So concluding that myoclonus dystonia, as I have shown, it is a etiologically heterogeneous group of disorder, and myoclonus dystonia is not always synonymous to SGCE mutation as it was thought to be previously. Similarly, basal ganglia mineralization always doesn't mean NBIA, because there are other conditions which can manifest as, which can have brain iron accumulation. And there is a significant overlap in the manifestation of different causes of myoclonus dystonia, but there are certain clues, as I mentioned in the table, can help you to differentiate among them clinically. But as we all know, genetic testing is often required to confirm the diagnosis. Thank you.
Very nice presentation, Dr. Anjali. I just want to ask you one thing, that
Yes.
is there any history of drug history in this case? Because I think I didn't saw that drug history.
Actually, she first came to CMC Vellore at the age of around 12 years. So at that time, the symptoms were very less. Like she was started only on clonazepam, and because of the MRI, everyone thought it is a NBIA, and she was not started on much treatment. And she came at the around 42 years of age for the follow-up, because the symptoms were slightly progressing, and then she came for follow-up. So when she came to us, she was on only clonazepam, which she was taking on and off. We started her on jonisamide, which caused some improvement, but not that much.
I just want to ask you that any drug leading to these type of presentation, because of the oral movements are there, very tremulousness is there, tremors are there.
Myoclonus, usually drugs cause oromandibular dystonia kind of thing,
like
but she is
rabbit.
having predominantly myoclonus. And it is like it was persistently present, and there was no history before the onset of symptoms.
Okay, thank you. Now I would like to invite next speaker, Dr. H.P. Sinha, for the presentation on hemimasticatory spasm, natural cause, and its response to botulinum toxin.
Good afternoon, everyone. Thanks, chairpersons. So my topic is hemimasticatory spasm, a rare facial movement disorder. I wanted to discuss this movement disorder because before presenting to me, this patient had already visited many physicians, neurosurgeons, without any diagnosis. She had received several forms of treatment, but there was no response. Even I was unable to diagnose this patient. I had to consult a movement disorder specialist, and then we made the diagnosis of hemimasticatory spasm. So perhaps the movement disorder specialist may not find this as surprising as we, but it was not so recognizable for us that time. So the case, 50-year-old lady presented to us with a history of 10-month duration with abnormal muscle movements over left cheek with feeling of stretching sensation up to the temple region. It used to increase on chewing and speaking, and used to cause discomfort and sometimes pain. And she also noticed that by maintaining the mouth slightly open, the contractions could be prevented. There was no sensory disturbance. There was no any twitch anywhere in the cheek or any other region of the face. There was no eyelid twitching. And on physical examination, the general examination was normal, and there was some hypertrophy of the masseter and the temporalis muscle. And apart from this, the entire neurological examination was unremarkable. So this was the movement. This is selfie image, so it is on the left side. Some rippling movement over the masseter muscle. The contractions were also palpable in the region of temporalis muscle, although it is not visible due to the hair. Here the contractions are more visible. And there is little hypertrophy of the masseter muscle also. So before coming to me, the patient had already been investigated thoroughly, and all her routine examinations, blood investigations were normal. MRI brain was also normal, EEG was within normal limits. And she had already received carbamazepine, oxcarbazepine, tetrabenazine and trihexyphenidyl without any relief. So we injected her with 50 units of botulinum toxin, which gave her around 60% relief. So on next visit after 3 months, the dose was increased to 100 units, and this time the contractions decreased to more than 90%. And with every injection, the spasms got progressively better, and actually the patient had presented to us 4 years back, and since then she has been undergoing repeated injections at the interval of around 3 to 5 months. Recently we injected her with only 50 units because the spasms were reduced dramatically. This is the video post injection, and we can see that the contractions, the spasm has subsided almost completely. So hemimasticatory spasm is characterized by paroxysmal involuntary contractions of the unilateral jaw closing muscles. It's an extremely rare disorder of the trigeminal nerve. Till today, only less than 50 cases have been reported, and it was initially described as masticatory spasm of Romberg by Grover in the last century. It usually occurs in association with progressive facial hemiatrophy or localized scleroderma, but may be seen without associated diseases. The most frequent triggers that precipitate spasms are speaking, laughing, or chewing. These triggers are always voluntary movements rather than sensory stimuli, as in case of trigeminal neuralgia. Brief spasms are generally painless. Prolonged spasms can be painful, as in cases of cramps. Sometimes it can, when the contractions are severe, it can result in temporomandibular joint dislocation, and in some patients, they may even bite their tongue or break teeth. There are case reports of this. And for the diagnosis of hemimasticatory spasm, the neurological examination should be normal, except for the spasm, but there may be hypertrophy of the involved muscles or the atrophy of the subcutaneous tissue that may occur in cases associated with localized scleroderma. Facial sensation is always spared, and no other cranial nerves are compromised. So what is the mechanism? The mechanisms are still not so clear. There is impaired inhibition of the masseter muscle contraction as a result of ectopic excitation that is supposed to play a major role, as suggested by the loss of silent periods during episodes of involuntary spasms. In hemifacial spasm, involuntary muscle spasm starts in the orbicularis oculi and usually spreads to the most of the muscles innervated by the facial nerve. In hemimasticatory spasm, however, involuntary spasms are selectively confined to the masseter, temporalis, and occasionally medial pterygoid muscles, while the lateral pterygoid muscle largely remains spared. So on the basis of clinical and electrophysiological findings, hemimasticatory spasm and hemifacial spasms are similar disorders that result from ectopic excitation due to focal demyelination, even though the site and cause of ectopic excitation is different. Hemifacial spasm is caused by vascular compression of the facial nerve at nerve's entry into the brainstem, whereas hemimasticatory spasm is caused by compression of the distal mandibular nerve branch, where the fascicles are more widely separated by the perineural tissue, whereas at the level of motor nerve root or intracranial portion of the mandibular nerve, the motor fascicles are closely grouped. So considering the common association of facial hemiatrophy, it has been suggested that facial hemiatrophy causes the trigeminal neuropathy. A trigeminal nerve branch to the temporalis and masseter muscle runs in a confined space between the lateral pterygoid muscle and the unyielding surface of the skull, where it might be easily compressed or stressed by deep tissue changes, results in focal demyelination of that branch. So usually in the evolved stage, if you know about the case, if you have already seen a case of hemimasticatory spasm, the diagnosis is not so difficult, but in early stage, you might get confused with hemifacial spasm, temporomandibular joint dysfunction, oromandibular dystonia, facial myoclonus, facial tics, and some other causes of abnormal facial movements. So the treatment is, as in our case, we saw that it doesn't respond to most of the medicines which are commonly used for movement disorders like carbamazepine, oxcarbazepine, tetrabenazine or trihexyphenidyl. But there are some case reports where they have suggested that initially some patients may respond to carbamazepine, but nothing works like botulinum toxin, so this is the treatment of choice. There is one case report of microvascular decompression where the patient responded completely to the surgery. So in summary, hemimasticatory spasm responds extremely well to injection botulinum toxin therapy, and it should be considered within the spectrum of facial spasms. Progressively, the dose of botulinum toxin goes down as the contraction becomes feeble with the passage of time. There is usually delay in the diagnosis due to the rarity of the condition. Therefore, the awareness of the condition and careful observation are crucial to avoid delay in diagnosis. Thank you.
Thank you very much, sir, for this wonderful case. And we have next talk. Yes, please.
What muscles you injected? This is masseter,
Masseter and temporalis were involved, sir.
and not pterygoid.
Pterygoid was not involved.
Thank you very much, sir.
Thank you.
For the next talk, I would like to invite Dr. Abhijit Kohar. He will talk on early management of Parkinsonism. Dr. Abhijit is from Raipur, and he works at DKS Hospital.
Good afternoon. First of all, thanks to Dr. Sanjay Sharma and the organizing committee. So today I'm going to talk about the early management of Parkinson's disease. So Parkinson's disease, when a patient with early disease is coming to the clinic of a physician or a neurologist or a neurosurgeon, so they have a mild symptoms, and there are the prescriptions where the patient is being treated with some drugs, including the dopamine agonist, the levodopa, or multiple medications. So I'm just going through the slides, and so that we can put some insight into the management. So when we say early Parkinson's disease, it means the Parkinson's disease where you are presenting with the bradykinesia, rigidity, and the tremors, and the prodromal phase is over. So overall, in the 20 years duration of the Parkinson's disease, half of the duration is in the prodromal phase, where the mainly non-dominant non-motor symptoms are dominant, then followed by the non-motor symptoms plus motor symptoms. So I'm just concentrating on this small portion. Now, what are the objectives of the treatment of the Parkinson's disease? When we have a treatment objective in the Parkinson's disease, one is the neuroprotection, management of the motor symptoms, management of the non-motor symptoms, and management of the treatment-related complications. So here we are not covering treatment-related complication. Now, as far as the neuroprotection is concerned, so this slide is very messy and is showing all the possible mechanisms of pathophysiology of the Parkinson's disease, including the mitochondrial disorders, oxidative state, glutamatergic transmission, and these are the dark circles which are under trial. And these light boxes is showing the trials which are already been done. In routine practice, we have some drugs like MAO-B inhibitors, levodopa, dopamine agonist, and calcium channel blockers, and delayed start trial of the levodopa, which shows there is no disease modifying effect of the levodopa in Parkinson's disease. So overall, today we don't have any drugs which has a definite evidence of neuroprotection in the Parkinson's disease. So as far as the motor symptoms are concerned, the Movement Disorder Society has given the guidelines, and these are the various drugs which are efficacious in monotherapy, including the levodopa and dopamine agonist. But when patient is coming to us, then the problem is what to start. What to start, when to start, how to start. So these are the questions. So when to start the treatment? So there are the two approaches. One is the wait and see approaches, and second is the start the treatment as soon as the diagnosis is established. So delayed initiation of the dopaminergic therapy for Parkinson's disease has been advocated for a number of years. So in the initial phase, the concern was that if with the early treatment of levodopa, the disease is going to progress and the complications will be more. So delay the treatment for the minor symptoms so that this complication can be avoided. So when we say this notion and the evidences, so evidences are very less. For example, this study including the 42 patients and the 26 has a early treatment while the 16 remains untreated. So they do not find any difference in the quality of life. But here is the stress on the quality of life. But again, the UPDRS motor score is changing, but it was ignored in this study. Similarly, in another study, it was found that if you treat early or if you treat late, there will be no difference in the quality of life in the treated and untreated group. So following that, there are multiple studies, including the DataTop and Tempo studies and the analysis of these studies. It shows that early treatment versus late treatment, the early treatment doesn't offer any benefit, while late treatment may have some problem. Why? Because when in the prodromal phase even, we have a low dopamine level. So for the couple of next 1 decade, the basal ganglion has the capacity to compensate. So it keep compensating, but one day it's not able to compensate almost when you have a dopamine reserve down by more than 50%, and we have a motor symptoms. So low dopamine in the brain causes subthalamic nucleus to those who are connected to the other parts of the brain. It causes a vicious circle. So if you are putting the dopamine early in the course, it is establishing the basal ganglionic circuit, leading to the longer lasting clinical benefit. And in various studies, it was found that disability is related to the duration of the disease, not to the duration of the dopaminergic treatment. So early treatment, it improves the symptoms of the disease rather than starting the delaying. Now, how to start the treatment? So patient is okay when you have decided to start the dopaminergic therapy, whatever it is, dopamine agonist, levodopa or MAO inhibitor. There are no clear-cut guidelines. Well, but how to start? So now there is the role of the education and lifestyle changes. So patient education is very important, because in our clinic what we see, we are not educating the patient about the Parkinson's disease, and he's just going by taking medication, he's not responding, so he keep visiting the multiple doctors. So first attempt when the patient is coming to the clinic, it should be the education of the patient, what the disease is, how it's going to progress, and what is the prognosis. Social symptoms of PD are very important, it should not be ignored, because because these patients, for example, like in the PD patients, they don't smile. Even 73% of the PD patients, they don't give a good smile. So somebody is gifting them something, they are not smiling. So the impression goes that this person is not good. 36% of the PD patient, they cannot produce a genuine smile. So it goes to a very negative message in the community, that because the community is not educated about the Parkinson's disease. Similarly, dysarthria. Patient is dysarthric. The next person is not knowing about that. Similarly, stigma. Problem is that he's a shaking patient, he's not eating properly, he's not able to express, it's a stigma. So all these things all together makes him depressed. They withdraw themselves. So in this way, social groups are very important. They, every city has a Parkinson's society. Even we should have this Parkinson's society in our city. So they all together work together and build a confidence. Next, come to the exercise. Exercise, even in a normal person, moderate to vigorous exercise significantly reduces the risk of PD. So you have aerobics, resistance training, gait training, balance training, and they all improve the motor and non-motor symptoms with various mechanisms. Here I would say the gait training is very important, because what happened, when the Parkinson's patient comes to you, you have two patterns of the gait problems. One is off freezing and one is on freezing. So off freezing, generally they improve with the medication, but there are the group of the patients, those who have on freezing, and they do not improve with the levodopa treatment. In that case, the gait training is very important. Similarly, balance training. Another way of treatment recommendation is LSVT, loud, Lee Silverman voice treatment. So it comes for the loud, first for the voice, and then it extended to the movements. So they are more concentrating with the amplitude rather than the speed of the disease. So amplitude means they just increase the amplitude in the gait as well as in the arms, so that their muscle work better, they feel better, and it shows long-term improvement in the motor symptoms. Similarly for diet. So diet is a very important aspect. We want a general healthy diet. Okay, so what is a healthy diet? In the general way, healthy diet is to reduce the diet which reduces the mortality and improves the health outcome. So for generally the general healthy dietary pattern is good, but some dietary patterns are made very specific. For example, the DASH diet for the hypertension. So another way of is the mind diet. Mind diet is the combination of the Mediterranean diet as well as DASH diet. They are rich in fruit, vegetable, low dietary products, and low intake of sodium and fats. So it has shown the reduce the risk of the Parkinson disease and increase the cognitive functions through various mechanisms, including the antioxidant and anti-inflammatory mechanisms and all. Now, choice of the drug. This is the important question. The purpose of presentation is choice of the drug. It's always a matter of debate. So there are the two concepts, levodopa for all patients, and other one is no, dopamine agonist or levodopa sparing strategies. So let's see. So when we say dopaminergic therapy, we see their efficacy, side effect. There is no neuroprotection, we already discussed. Now levodopa is the cornerstone of the gold standard of the treatment. It has been more than 50 years we are using it. Now the problem with levodopa is that it behaves a bit different. It has a honeymoon period which can be from the 2 years to 5 years. After that it develops the on-off phenomena and then dyskinesia. So on-off phenomena is there, and the dyskinesia may be the morning of dystonias. In the morning our patient is having toe extension of the great toe, and then the diphasic dyskinesia when there is a upsurge and down of the dopamine level, and peak dose dyskinesia. So there are just few videos. So this can be small, this fine choreiform movement. You can have a violent dyskinesias, or this is a very typical of diphasic dyskinesia involving the lower limbs mainly. So these are all the complications of the levodopa therapy: wearing off, delayed on, dose failures, random on and off. So it generally appears after 2 to 3 years of the therapy. Now dopamine agonists. When we say dopamine agonist, we have almost 10 drugs available in the market, but we generally use two commonly used drugs, that is ropinirole and pramipexole. So what are the problem with these drugs? With levodopa, this is the nausea, dyskinesia, motor fluctuation. But when it's come to the dopamine agonist, we have more side effects, including the impulse control disorder, dopamine agonist withdrawal syndrome, excessive daytime sleepiness, hallucination, and orthostatic hypotension. It is also along with the orthostatic hallucination with levodopa, but it's more with the dopamine agonist. And we are more concerned with the impulse control disorder. So what exactly the impulse control disorders are? They are failure to resist an impulse or temptation to control an act or a specific behavior. So they have an impulse. So they can be classified as a pathological gambling, compulsive buying, hypersexual disorder, binge eating. So what is the problem? Problem is that when we prescribe the dopamine agonist, we do not inquire about these symptoms in the follow-up. Patient says, I am okay, I am okay. I am giving you 2-3 examples. I am sorry if I am taking more time. One of my patient, he was on dopamine agonist for almost 2 to 3 years. So he came from outside and he was okay. But you have to ask for the symptom, and I asked his wife about the hypersexual disorder. So she was crying like anything. So she in our society, it's very difficult to disclose, but it was a problem. Compulsive buying, one of the millionaire person, he's just buying. He's just buying houses, he's just buying vehicles, costly vehicles. So the family members are thinking, oh fine, we have a lot of money, but it was an impulse control disorder. Gambling, generally we Indians don't do gambling much, but it's one of the symptoms. People, they do online lotteries and all. Similarly, there are the group of the symptoms, that is impulse control related disorders. This more common is your hoarding. This acquisition of failure of the discard large number of the items with no objective value. He's just collecting. Another is hobbyism, unnecessary hobbies, funding, repetitive, purposeless behavior. So one of my patient who was on dopamine agonist was a computer engineer. What he was doing, I asked him, क्या करते हो दिन भर, काम तो करते नहीं हो. He said, his wife said, कुछ नहीं करते. Computer engineer है, सुबह उठते हैं, पूरा लैपटॉप खोलते हैं और शाम होते तक फिर से उसको लगा देते हैं. He's getting interest in that. So we have to, another patient, it has been 2 years on the low dose of pramipexole. Initially she was doing good, but when in the follow-up I noticed, she is so happy, she's smiling all the time and talking to me very nicely. I asked his son, what is the problem? He was happy because mama is very happy nowadays, I am so happy. That is not the problem. You are happy, but I am sad because you are unnecessarily happy. So what is the incidence of impulse control disorder in our community? It's in the AIMS study, it is 11%. at least one any impulse control disorder is almost 25%. So the incidence is quite high. So these are all the complications with impulse control disorder. So now what? Now if we are starting the levodopa and dopamine agonist, so what are the comparison? In short term, we see in short term, 2 to 5 years duration, dyskinesia is more in the dopamine group compared to ropinirole in the first study, but motor score is more improving in the levodopa than ropinirole. Similarly, in the second study also, the CALM-PD, the dyskinesia is more with levodopa, that is 31% versus 10%, while the UPDR's motor score is more improving in the levodopa group. But what happened in the long term? So this is the largest study, one of the continuing for the 7 years, 528 patients in the levodopa, 632 in dopamine agonist, and MAO-B has a 460 patients. So in the duration of the 7 years, the equivalent levodopa dosing of all these three groups were comparable. And when it's come to the dyskinesias, almost same group of the patient, almost 33%, 36%, they have a dyskinesia in the long term, almost in the 7 years of duration. So now what? So this is one of the circle given by the Professor Oscar Gashnik, that the levodopa come into existence in the 1967. And from 1967, that time the medication was not there, so there was a careless use of the levodopa, and then gradually the dopamine agonist, it came into existence. Now what happened in the era of 1990 to 2000, it developed that levodopa is causing harm because of the some mechanism, including the oxidative stress and this killing the basal ganglia, and then levodopa complication was started, and it was thought the levodopa is deteriorating the disease, so they were using more dopamine agonist, and this decade was levodopa phobia. Now after that, what happened, gradually these side effects, they came into existence, and now we can say it's a dopamine agonist phobia, because dopamine agonist has more side effect than the levodopa. So now we are again shifting towards the levodopa treatment. So this is the levodopa circle. It's very nicely presented in a conference with Professor Gashnik. I acknowledge him here. And same in this diagram, it's quite, I'm not sure it's very clear for you, but it's very nice. So in the patient who is having early levodopa, they have a initially good response to medication, then levodopa dose is increasing, they have fluctuations, they have more fluctuations, but ultimately there is a low early disability. But it's the same thing when you're starting with the dopamine agonist, they're having more side effects throughout the course, and now you have to add levodopa. So when you start with the patient on the dopamine agonist, after 2 years, you have to add levodopa for better control. So ultimately you have to add levodopa, and then at the end you have a high early disability. So disability at the end of 7 years or in the long term is more with the dopamine agonist, along with the side effect with the less symptomatic improvement. So in our movement disorder clinic, we have seen we have almost 150 patients follow up in the last 2.5 years, and most of them are treated somewhere else or referred from some major center, and the majority of them on multiple medication, and they definitely had the complications. Less than 20% patients, they were on the dopamine agonist monotherapy. Most of them were in the combination therapy. So far we have the 3 patients who underwent the DBS, and few more are waiting. And in our experience in the rough data, patients are very well doing on the levodopa more than dopamine agonist in terms of the UPDRS motor scores. They are not doing very good in terms of the UPDRS scoring. They are a bit disabled. When they are shifting on the levodopa, they are doing better. A special, due to time constraint, I am just going through this. So now I would say most of the dopamine agonists, they delay the onset of the motor complication for up to 3 to 5 years, but in short term, dopamine agonists can give you the benefit, but in the long terms, the disability is more in dopamine agonists. So once we write that prescription on the day 1 for the Parkinson's patient, we are writing how his course is going to be in the next 10 years or 20 years. So no doubt levodopa is still superior in improving the motor function, but it doesn't mean that the dopamine agonist should not be started. So it's in the discretion of the physician. If the symptoms are very mild, and the patient, we are explaining the patient about the levodopa and dopamine agonist, the complication, the patient can make his own choice. Now just a slide about the management of the tremors. So management of the tremors, these are the various structures which are involved in the tremor generation. And tremors, one can have a rest tremors and or the action tremors as well as in the Parkinson disease. The problem in tremors is that the tremors are problem for whom? For the doctors or for the patients? Because for patient is more as a cosmetic rather than it's really interfering in his daily activity, maybe. But they are the rest tremors. But when they are acting, the tremors are going. Okay, so I think the education has a very important role. We have to make them understand that these tremors are very difficult to treat. They are not going so easily. And as far as the medication is concerned, levodopa treatment is better or equally effective than anticholinergic. The problem with anticholinergic is that once you start the anticholinergic, it may be giving some benefit to the patient, but it's causing harm to the patient. So a lot of side effects including the cognition, urinary. Patient is already having multiple neurotransmitter deficiency. So if you ask me, the trihexyphenidyl or the pacitine which we write is really not a very good choice for the elderly patients for tremor. If you educate them that levodopa will take care of the tremors, so levodopa is equally effective. Sometimes in some patients, the levodopa requires a very large dose to suppress the tremors. In that case, you cannot increase the dosing of the levodopa just to suppress the tremors. Patient education plays an important role. And the DBS is also, having very good efficacy in the reducing the tremors. So Parkinson treatment cannot be live without the non-motor symptoms. So there are the various symptoms of Parkinson disease, including the cognitive decline, dementias, visual hallucinations, and so on. So almost gut from gut to brain axis, so many things are involved. I cannot go on everything, but this graph is really nice. It shows that when you when there is a prodromal symptoms and when we have the clinical diagnosis here and when you start the dopamine therapy, the motor symptoms they improves better, but the non-motor symptoms, it's not necessary they will improve, they keep worsening. So in the long term, it's not only the motor symptoms, the non-motor symptoms they make more problem for the patients rather than the motor symptoms. So non-motor symptoms should be treated accordingly. Sleep is very important. RBD has the 42% incidence in the Parkinson disease, and RBD has the highest predictive value for synucleinopathies. So other than other symptoms, it's the RBD. When the patient is having RBD, it is almost sure that 82% will develop either PD or DLV, and it's very problematic for the patients. We have to ask this question. They will describe it that wife says कि रात को सोते हैं तो बहुत बड़बड़ करते हैं, हाथ पैर फेंकते हैं. In fact, they have a violent behavior in the night. We have to ask all these questions. So treatment of this is really necessary for a better life. So these are the various structures. I'm not going to detail. These are the various structures involved in the various non-motor symptoms. And we can use this medication including the clonazepam for sleep disorder. Melatonin and the clonazepam has a better efficacy. For orthostatic hypertension, we use fludrocortisone and midodrine in our clinic. Drooling, botulinum toxin, and atropine. Drooling is very important. It creates a lot of problem, especially in the night time. Patient is on this lateral position and he's wetting his bed sheet. So atropine drops are very important. Those eye drops, atropine drops, you ask for the patient, just put 2 drops under the tongue and it will work like anything. Now the next is the best dosing schedule. I'm not making any slide for this. The best dosing schedule for levodopa. So generally we give levodopa in the TDS form and the 6 hours, but it's not the rule, because the levodopa has a very different pharmacokinetic and the pharmacodynamic, and it's not a rule for everyone. So there are the few people, they are short duration responder, they are the long duration responder. Few people, they in your practice you have seen that few people they just do very good on the single dose of levodopa, 2 doses of levodopa, and they are good for 24 hours, but few patients they require more than 3 levodopa doses. So it's all about the pharmacokinetic and pharmacodynamic, which is individual for every patient. There's nothing abnormal about it. The target is minimum dose of levodopa for the patients, and the monotherapy should be there. So I'll conclude here that treatment of the PD should be started as soon as diagnosis is confirmed. PD education should be a part of the treatment. No PD treatment cannot be continued without the education. There is no effective protection. So far levodopa is superior for managing the motor system, and monotherapy should be the target. Non-motor symptoms, they should be addressed very effectively. And yeah, treating a PD patient always enhance your knowledge and insight into the disease process. Thank you.
Dr. Abhijit, a very nice presentation and a very elaborated presentation on early management of Parkinson's disease. I just want to know your views on that new nutraceuticals. Are they really helpful for these patients?
Which one?
Like different nutraceuticals are recommended for these like neurodegenerative disorders. The companies are recommending
No,
like arginine,
we are,
carnosine.
yeah.
What is your view on that?
We are not using that because we still haven't, the literature is not shown me the evidence for that. So we are, if you ask me the single question, the patient is with me, I'll just go with the levodopa treatment, that's it. We are, even that for neuroprotection, we are not giving.
Sure. See, one thing which
Yes.
I wanted to tell you, you did mention about that in initial stages, and obviously all the tertiary centers also of Movement Disorder Society, they mention that you should use only physiotherapy to begin with in any early patient of Parkinson's disease. And you also very vehemently said that their gait should be improved. So another added thing which can be added is music therapy these days to the gait training, because that helps immensely in gait training by a process of entrainment.
Right, sir.
Thank you, Abhijit sir.
Yeah, please, sir.
What is your take regarding sustained release preparation or control release preparation of DOPA as well as DOPA agonist? Something if you want to say.
So, yeah, so when we are giving the levodopa, the sustained release, there is a problem with the absorption. So we have seen few prescription where the sustained release levodopa is giving in the morning time, in the afternoon time, or half or BD or TDS doses. So I think we should discourage it because once you started giving this treatment and the pulsality is defective, then there is a aberrant circuit in the brain and which leads to the early formation of dyskinesia and complication. So there are the group of the people, they don't believe in the sustained release levodopa even. So as far as we are concerned, we give it in the night time only, not in the daytime.
One more thing in that sustained form is that that initiation delay is there. The patient has got a significant relief with the normal preparation, say effectivity, onset. But the sustained preparation, the patients may complain about that the response started, say, later. Not very sustained also, but later, as compared to the normal form.
Yeah.
So the initiation of the effect is also, because they want that immediate effect after taking the tablet. This is the problem with the sustained.
And that is not the constant. For example, the immediate release levodopa, we have a pattern that in the 20 minutes is going to on. So it's not, and it's happened every time, 20 or 30 minutes is going to on, but when it goes to the sustained release, it's not necessarily that he will on the 30 minutes, maybe in the 1 hour, maybe after the 2 hours, or maybe in the early. This kind of thing happens.
Thank you, Abhijit sir. Because of time constraint, we have to move early. Our next speaker is Dr. K.K. Bhoi sir. He will talk on reversible Parkinsonism and osmotic demyelination syndrome.
बंद कहाँ से हो गया? Hang हो गया. It's hanged. तुम्हारा माउस ही नहीं चल रहा यार.
नहीं बंद करो.
क्लोज कर दो.
मेरा निकल. मेरा वाला कौन सा था? ओडीएस. मेरा ओडीएस ऊपर केवल. कौन सा? Good afternoon, everybody. Today my topic is osmotic demyelination syndrome. For MBBS student pre-PG examination, osmotic demyelination is only multiple choice question MCQ. What is the most common cause of osmotic demyelination? Hyponatremia. That is all. And during MD for physician, it is more than that. That is, what are the causes of hypotonic, how to treat this in ICU setting, that is very much important. Otherwise, patient will lead into neurologist and movement disorder specialist for its complication, whether it involves the parts of the brain, pontine part or extrapontine part, movement disorder parts and behavioral part. That is very much important to neurophysician. PBLC it is considered a rare disease, but now the different types of modalities of MRI, diffusion mutate, it picks up, and this osteometric syndrome is now a common, and we can treat simply by correction of sodium and by conservative treatment with movement disorder and medication and antipsychotic drugs. But there is not available any specific therapy for osmotic demyelinating syndrome, only to treat the disease part and the conservative part. So there is many of us at nihilistic approach for treatment of osmotic demyelinating syndrome, because patient will improve slowly, it will not bother us, and there is no specific treatment. We are not taking much interest in this syndrome. This is a case of 40 years old, this case, in chronic alcoholic patient admitted with history of gastritis vomiting for 4 days, admitted with ultrasonic. There is without any significant focal deficit, routine examination normal, except sodium and potassium was low. Sodium corrected very slowly over 3 days by ICU physician, and patient improved and discharged in 1 week. Patient after going home after 4 days again he admitted on 9th day with Dowgenous convulsion and extrapyramidal syndrome. And again now the sodium is normal, potassium normal, and all investigation including CSF, EEG, CT scan, in MRI, all normal. Patient improved with supportive treatment. MRI repeated during the admission on 15th day. So there is involvement of both pontine involvement, central pontine myelinosis, also with extrapontine involvement, basal ganglia, thalamus, all involves. This means patient initially have normal neuroimaging, but after 2 weeks, patient developed demyelination in both pontine and extrapontine part, but patient is improving, although there is appearance of lesion in the MRI. That is, there is no direct correlation between the MRI images and osmotic demyelinating syndrome. Sometimes MRI image appears late, sometimes early, but patient will improve. Sometimes the images there is extensive changes, but patient is stable. So it is treated with conservative treatment with levodopa, carbidopa, clonazepam, baclofen. After 2 months, patient the Parkinson's features improve significantly, and patient able to return to its work within 2 months. After 1 year, the residual dystonia is treated with botulinum toxin. So there are different cases. Another case with cognitive patient with cognitive behavioral problem with compulsive water drinking. They are also treated with correction of conservative treatment. Another case, third case is by prolonged diuretics use in renal failure patient. That leads to osmotic demyelination. Another case, fourth case is by patient presented with recurrent vomiting. That also involves both central pontine and extrapontine part. Another case is by patient is refusal to take food because of comorbid condition presented with seizures and extrapyramidal vision, apathy, depression. That also improve slowly with conservative treatment. It was published, this series was published. So where we should take care of osmotic emulsion into our picture, because till that there is no specific treatment, whether IVIG, plasmapheresis or steroid or any treatment, there is no specific treatment, there is no long case series, there is no randomized control trial available. So we should focus on osmotic methylation syndrome. It was first described by Adams 1959 in alcoholic patient in a case of hyponatremia. And that patient usually leads to locked-in syndrome, suitable for C quadriplegia with different types of movement disorder and psychotic abnormality. That usually reversible with conservative treatment. And there is other drugs like diuretics, some psychogenic polydipsia, Burns patient, liver transplant patient, malignancy, and prostatectomy patient, they usually come across hyponatremia. The mortality is 10 to 20%, but I am talking about this is not overall hyponatremia. Some are mild cases. This is for severe cases for ICU patient only. So it involves central part mostly and extrapontine, and combination also in 10 to 20% of cases. Usually it involves the gray and white matter. Because of apoptosis of oligodendrocytes, usually action is spared in central pontine myelinosis. In extrapontine part, there is combination of parts affected like thalamus, basal ganglia, internal capsule, cerebellum, subcortical white matter. There are other diseases we should take into account like hypoxic ischemic encephalopathy, Wilson disease, where there is putamen globus pallidus are affected thalamus. But in extrapontine myelinosis, globus pallidus is usually spared. We should see in the MRI picture. And other causes of basal ganglia we should take care of. But there is no significant correlation between the MRI images and clinical picture. That is one study in this case. There is increased effect of diffusion rotated in ADC map in the right side and left side the level of the sodium. That is gray area in between sodium level 135 to 145. That is normal level. When it is less, the sensorium downs and become convulsion and comatose patient. And ADC map involvement sometimes correlated, sometimes does not correlate. That is very much important. So MRI changes usually appears 2 weeks after the symptom of hyponatremia or correction of hyponatremia. And it is may be reversible after 1 to 2 years. And correction of hyponatremia should be very slower, less than 8 milliequivalent per day. And as there is, I have told there is no specific treatment. There is some series or single case study of steroids, methylprednisolone, or some in cases of IVIG and plasma exchange, because I thought that it may be due to inflammatory changes in the brain. Sometimes tried with thyrotropin releasing hormone. Some physician critical care medicine they tried. Again, putting them into hyponatremic condition with desmopressin and dextrose to improve the mental condition. But there is no randomized control trial. So it is, the job for us is to control this movement disorder part, psychotic manifestation. But for correction of hyponatremia, it is very most important part is for critical care physician. That is, suppose in case of into 3 groups: hyponatremia with increased edema, hyponatremia with euvolemia, hyponatremia with hypovolemia, 3 conditions. And treatment is we should accordingly. Suppose hypervolemic, so osmolarity is less than 280, urinary sodium less than 10, as in case of cirrhosis liver, renal failure, and congestive heart failure. For mild cases of hyponatremia, that is around 120 sodium, vascular restriction is sufficient, and furosemide is added in some cases. In other cases, in every cases we should treat underlying disorder also, heart failure, cirrhosis, everything. In severe symptomatic hyponatremia, less than 115, in volume overload patient, vascular restriction along with hypotonic saline is given, and it is according to critical care medicine, NEGM. The sodium deficit should be calculated 0.6 per ml, 0.5 per female in weight into desired sodium level minus actual sodium level. In other condition, associated with isovolemia, urinary sodium less than 10, and osmolarity less than 280. Water, in this case, if mild cases, that is 120 sodium, furosemide along with sodium normal saline and potassium chloride infusion. In SIDH, mainstay is the fullest restriction, and if required, desmocycline in few cases. In emergency situation, if sodium is less than 115, hypertonic saline along with furosemide. In all symptomatic patients, hypertonic saline along with furosemide or hypertonic saline with water restriction as per the patient condition in ICU. In hypovolemic condition, if osmolarity less than 280, sodium less than 10, SSVD usually gastroenteritis. In this case, if sodium, urinary sodium more than 20, or if patient is volume depleted, then normal saline should be restricted, that is 500 ml per hour until there is no orthostatic hypotension. Then followed by normal saline using potassium chloride infusion until desired level of reached in mild cases. In mild cases, target level is 130 per sodium.
Thank you, sir. I invite any questions, if any question.
You just mentioned in the second last slide that in emergency give a hypertonic saline along with furosemide. So why not on that situation use a tolvaptan, which is a free water loss?
Tolvaptan we can use in a hypervolemic condition.
No, so in emergency situation.
Emergency situation, hypertonic saline.
Using furosemide also, no?
Furosemide also.
So if you are using furosemide, because you are saying that hypertonic saline plus furosemide, so why not to use tolvaptan? It is better than furosemide for these type of patients.
We can also use tolvaptan in hypervolemic hyponatremia condition, and in sometimes resistant type of isovolemic hyponatremia.
Thank you, Dr. Bhoi. I think there is no more questions. In this movement disorder session, total 7 talks were there. I think this would be the last. I would like to invite Dr. Arpit Agrawal, and he will present his talk on non-ketotic hyperglycemia and movement disorders. Welcome, Dr. Arpit. Dr. Arpit is from Raipur, and he works at DKS Super Specialty Hospital. Welcome.
Thank you, Dr. Sanjay Sharma sir and the organizing committee for giving me this opportunity. Today I am presenting non-ketotic hyperglycemia related movement disorders. First of all, I would like to thank my colleagues for contributing cases in this rare movement disorder. And since this is a movement disorder symposium, I will directly go to my cases. This was my search strategy. It has been variously named as diabetic steatopathy, hyperglycemic, non-ketotic, hemichoria, hemiembolism, and various other names, the most latest and most appropriate being diabetic steatopathy. This will be the outline of my talk. So I'll just start with the cases, then we'll discuss the theory part later. Something, how will I run the video? Wait, there was one video here. Anyone? Yes. ऐसे ही डाला हुआ है। I will continue with the theory part, then I will come back and show the videos.
Arpit, you just start, na? It's quite delaying now.
Yes, sir.
Slides are not opening.
Yeah.
All these things has to be.
So, sorry for the delay. So I can show this video. I think this one is running. So we can see bilateral coriform movement, including there is jerking of proximal both upper limb also. So this lady is having bilateral chorea and melismus. This lady is just having a coriform movement in the left upper limb. So SCNH was first described by Bedwell in 1960s. It is characterized by a typical triad including unilateral involuntary movements, contralateral striatal abnormalities, and rapid remission of symptoms after correction of hyperglycemia. This non-ketotic hyperglycemia is a rare cause of movement disorders. It can present with hemichorea, hemimelismus, or a combination of both. Although the typical triad may not hold true, there may be bilateral involuntary movements, There may be bilateral striatal abnormalities, and even the side may not match with the abnormal limb movements, and there may be rapid remission after correction of hyperglycemia, but it may persist up to 6 months. It has been seen it is more commonly in elderly diabetic women of Asian origin who are non-compliant on anti-diabetic drugs, who are having prolonged hyperglycemia. It is characterized by hyperdensity and T1 hyperintensity in the striatum. On CT and MR there is T1 hyperintensity and T2 flare hypointensity in the striatum. So this article has tried to define it: hyperglycemic condition associated with even one of the following: choreoabelism and striatal hyperdensity on CT or hyperintensity on T1 weighted MRI. Prevalence is estimated to be 1 in 1 lakh. That is quite underestimated actually, because many physicians are not aware of the disorder and they tend to miss it. Ethnicity is more common in Asian, but that is now not so. It is also seen in Caucasian and Hispanic and also Indian population. Male to female ratio is approximately 1 to 1.7. Mind you, these are all very vague and rough estimates, because the number of cases reported is very less. The largest series is of 12 patients and largest meta-analysis is of only 56 patients. Currently we are having 13 patients with data with us, and 2 patients are currently admitted also. So this is in short pathophysiology of the condition. It is characterized by metabolic acidosis, energy depletion, decreased GABA and acetylcholine levels. So basically there are 2 theories. One is metabolic theory and another is vascular theory. For the occurrence of this condition, both are not mutually exclusive. There is diminution of the inhibitory pathways in the striatum, in the basal ganglia, leading to hyperkinetic movement disorders, which may vary from patient to patient. And the reason for the occurrence of it in more commonly in elderly women is because of loss of effect of estrogen. Histopathology is non-specific. I'll just say that I'll not go into the details. We conducted an ambidextrous observational study, and we intend to follow all patients up to 1 year. Currently we are having 13 patients. This was yesterday. So with the exception of 2 patients, all the patients were already diagnosed with type 2 diabetes, were having a prolonged illness, and all were either non-compliant or medications, or the glycemic control was poor. So this is our list of patients. I hope it is visible. So all first, age is no bar, although most of our patients are 60 plus. They present more commonly with chorea, but also with hemiballism. Type of diabetes, all our patients, we are medicine people, or type 2, type 1 diabetes cases have been reported. It's not exclusively in type 2 patients. So 7 of our patients were duly diagnosed, others were known diabetics. HbA1c, as you can see, is more than 9 in all of our patients. The initial RBS level was variable. 1 patient, 2-3 patients even had a normal RBS, but if we see long-term glycemic control, that was poor. Some had, most of our patients responded well to glycemic control, and our clinical experience is the drug that was found most effective was haloperidol, low dose haloperidol. So I'll just summarize: type of movement disorder, hemichorea, hemiballism. in the order of frequency, most common is arm leg. It may be arm leg face, isolated arm or isolated face. Onset may be sudden, so sudden that the relatives get very anxious about that, or it can be insidious. Most of patients have ketone bodies negative, but again, even though my lecture's title is non-ketotic hyperglycemia, some of these patients may have ketosis. So still we are far to go to know its pathophysiology. So these I have already discussed. In SPECT, basal ganglia may show hypoperfusion, and in PET it can show glucose hypometabolism. So this is a treatment summary. We have to correct hyperglycemia, and you can use any of the drugs because there are no RCTs or clinical trials about that. The most common drugs we use are tetrabenazine and haloperidol. Prognosis is good. It's a curable disease, but the duration of treatment may vary from a day to up to 6 months. I think I have already discussed most of the points. Thank you. I'll try to run the videos if possible, if I have time, maybe a video or two.
Till Arpit is searching for the videos, anyone is having questions regarding this movement disorder session to all the speakers?
So Arpit, this movement disorder, these are the one-time event, or the same patient can have a recurrence of these movements? What is the literature search?
Sir, till now I have seen 3 case reports that had a recurrence after the glycemic control became poor. But in our 13 patients, we have till now seen no recurrence, and the maximum follow-up of ours is around 6 months now. And ours, the largest case series is 12. We already have 13 patients till now. So I can, since this is visible, there is hyperdensity of the putamen and caudate on the right side. It is also on the left side, but the right side it's more prominent. So I'm sorry, I'm unable to play the video. This one, it's working. Thank God. So this gentleman is having a almost dance-like movement in the left distal upper limb and left lower limb. This is a follow-up video after 3 months of treatment. Initially, it was so severe that he was not able to walk. So I'm sorry I could not show more videos, but I think I'll stop.
Thank you, Arpit. You tried hard, and lastly found one video, interesting one. And one comment I want to add in this, that hypoglycemia is also can cause these type of movements.
Yes.
And
yes.
I reported one case of that hypoglycemia induced T1 hyperintensity with this coriform movements also. Mostly hyperglycemia described, but very less cases of hypoglycemia also.
Yes, that is true. That's what I told in the on the outset. Nothing is very specific in this disorder. There may be ketosis also, and even there may be unilateral limb involvement and bilateral involvement in the imaging, or vice versa also is also true.
Thank you, Arpit.
Okay, thank you.
By this, we are concluding this session.
I will request the chairperson to felicitate all the speakers, Dr. Sanjeev Sinha sir, Dr. Tarun Nagpal sir, Dr. Anjali Chokse ma'am, Dr. H.P. Sinha, Dr. K.K. Bhoi, Dr. Arpit Agrawal, Dr. Bindu Menon ma'am, Dr. Abhijit sir. Hello. Now I will request the speakers to felicitate the chairperson. For the next session, I will request Dr. Sanjay Sharma sir, Dr. Pankaj sir, and Dr. Bhuvan sir to chair the next session.
Pankaj Bhuvan. So good evening. We are into a last session of today's evening. We have three fantastic speakers with it, and it's my privilege to introduce Dr. Sanjeev Gupta, who is a neurosurgeon, and he is organizing secretary of this conference. The beauty about Sanjeev, he draws such an excellent picture on a computer, and many of his pictures are published on the front page of a front cover of a Neurology India. So I have seen a couple of him printed into a Neurology India, and I have seen elsewhere. I have also utilized this couple of a picture into my articles, one for a leprosy and another for Alice in Wonderland syndrome. So may I call upon Dr. Sanjeev Gupta, the first speaker. He is going to teach us. Please take seats. Hello, please take seats. Umesh, take seat. Be seated.
Good afternoon, everyone. While my presentation is getting set up, as an organizing secretary, I thank all the delegates, speakers who made this conference successful. And I also thank Dr. Sanjay Sharma sir, who encouraged a neurosurgeon to speak in front of neurophysician. I feel hesitant as I am the only neurosurgeon speaking in this neurology hall. And I have a disclaimer that my talk is more of a motivational and show-off talk. So I will be just presenting this. अपना कन्वर्टर लगा देना नहीं होगा पेन ड्राइव आ गया नीचे चला के आया मैं क्या हुआ कॉपी कर लीजिए पीछे से चल रहा था ये. The same laptop was working downstairs. Solved. निकल गया. इसको वहाँ टेबल पर रख दो. इसमें चलेगा?
सादे लैपटॉप पेन ड्राइव के लिए
चालू हो जाएगा.
वीडियो नहीं.
ये आधा क्यों आ रहा है? It's okay, let me see. पूरा आ रहा है ना? So what are medical illustrations? We can simply define a medical illustration a place where science meets the art. The famous scientist Einstein once said, "A picture is worth 1,000 words." Although medical illustrations are being made since the time of Leonardo da Vinci, but it was Max Brodel who is considered the father of medical illustration. He was a full-time medical illustrator at Johns Hopkins. These are some of his neurosurgical illustrations from the late 19th century. He made the illustration for many surgeons and physicians like Harvey Cushing, William Halsted, Howard Kelly, and Carl Ludwig. This is the man who made early surgeons and physicians famous. Harvey Cushing was a resident when Max Brodel joined the Johns Hopkins. Cushing learned this art from him. He himself was a great artist and used to draw his operations on paper. Just appreciate this illustration made by Cushing. See the sense of 3D and depth. How realistic it looked. The patient shown in the first picture was actually his mentor, the great William Osler, also known as the father of modern medicine. Many people may argue that in present era they have very high resolution cameras. They can just click whatever they want. The clicking is a one-time phenomena, while drawings take a lot of effort. In my opinion, both these modalities do not substitute each other. Rather than they complement each other. There are many things which drawing can achieve, but camera cannot. Let me show you some examples. A photograph can capture an image in real time, but what if you need to demonstrate such structure in a section? Just appreciate this illustration of normal delivery made by Max Brodel in the late 19th century. It had been the basis for teaching for generations. No camera in the world can capture this in a live human being. An illustration is a better teaching tool, especially for explaining physiology. This is an actual electron microscope photograph of a neuromuscular junction, which is very difficult to explain to the students, while on the other hand, it can be easily explained to the students by an illustration. The different color combinations help in better representation and understanding. This is another example showing the atherosclerotic plaque in the carotid artery. Illustration is better explaining than the actual picture. How will you explain the process of demyelination to a student or a patient? Can a camera capture this? No, while it can easily be shown with a drawing. If you see any photographs taken during the actual surgery, the presence of blood obscures so many structures. A surgeon can understand, but for another person, it looks like a maze. A simplified illustrative version of the same photograph can represent the surgical technique and the anatomy. An illustration has more freedom of expression than actual photograph. The different color coding in illustrations permit to the enhancement of the tissue and may help to differentiate tissue. The illustrator may enhance the area of interest by suppressing the background. Art can show you the object in different planes in a single picture, while this is not possible with the camera. God has not done much color coding for tissue differentiation, so we need illustration to do this job. By an illustration, you can create see-through images, which are very helpful in showing the trajectories and the anatomical relations with surface markings. The artist can draw these see-through images if properly guided. An illustration is a better teaching tool, and sketching is a great tool to demonstrate the physiology of disease. Many of you must be editor or reviewer of the journals. Just recall how you rate an article when it consists of a beautiful illustration. If you are submitting a research paper, believe me, an illustration acts as X factor to convince reviewers and readers. You can also use illustration for counseling the patient about the disease process and prognosis. For surgeons, sketching provides many benefits. The sense of detailing, fineness and depth improve your surgical skill. A neurosurgeon with artistic skill can preoperatively simulate surgery. After starting making illustrations, my sense of depth appreciation has gone much. I see a thing in different way. I appreciate more fineness. I observe how the light is falling on the object, how the shadows are creating, what are the shades. And for giving a 3D look, you just need these three things: shine, shadows and shades. You can draw on canvas, paper or a screen. I prefer a digital screen because it is easy, it does not soil my hands with colors, and there is no issue of drying of colors. And it saves your work wherever you live. It also provides you with the liberty of doing undo and redo like a computer. You can mix colors. You can choose brush type, size as well. A single pencil stylet does all the tricks. For artwork creation, you need certain tools. In the current digital era, you need a touch screen and software. There are many available in the market. I personally prefer iPad Pro as it is very user-friendly, but for iPad Pro, you need to download the Procreate software. The professional artist uses more complex gadget which requires a formal training. Let me confess, I was never an artist. I always thought that I can't do it, as I do not possess that sort of dexterity. But I was wrong. The dexterity is inbuilt in every human being. We just need to express this in form of art. My motivation came after reviewers' comment on this article. The pathophysiology of hearing was so complex that the reviewers demanded a pictorial representation. I created these drawings on Microsoft Paint. They accepted, but I was a bit unsatisfied. So I started looking and I came across this man. He is Peter Lawrence, a full-time medical illustrator working with Michael Lawton at Barrow. He makes mesmerizing illustrations. I followed his illustration and I sacrificed my Netflix time and invested in watching YouTube tutorials. So after getting motivated, I simply kicked out T from Kant. I decided I can and I will watch me. This was my first artwork created for my technique of extra-axial endoscopic third ventriculostomy. This was nowhere near to perfect, but was something. For submitting a surgical video to operative neurosurgery, patient position and incision is an essential requirement. Before surgery, I forgot to take the photograph, so I created this illustration. For this video article, I realized that manuscript was looking boring as there was no extra figure left to include. So these illustrations were created showing surgical anatomy of cerebropontine angle and 3 different types of aneurysm, which has never been shown before in the literature. This illustration of endoscopic clipping of ACOM aneurysm was just an extension of earlier shown illustration of extra-axial endoscopic third ventriculostomy. See, the detailing and sense of depth are getting better with time. Seeing this illustration, Neurology India invited me to contribute to the cover page, and an intradural extramedullary spinal tumor resection using tubular retractor was showcased on the cover page. Since then, my illustrations are finding the place on the cover page of the Neurology India. Recently, for an atypical Hengeman fracture classification, the reviewers demanded diagram to help understand the difference between the different fracture types. These illustrations were created, which is the first of its kind in the literature. The illustration about selective vestibular neurectomy for intractable vertigo got placed on the cover page of Neurology India. Similarly, this image showing a case of torticollis and a surgical procedure was published on the cover page of Neurology India. My fellow neurosurgeon was submitting an article for publication. For effective representation, he required an illustration for showing the patient position and incision. I created this. Dr. Sanjay Sharma sir want to demonstrate a case of supraorbital nerve involvement in a case of leprosy. So we created this see-through image. My fellow neurosurgeon was asked to deliver a lecture on dural AV fistula. He drew this simple image, but it was not looking appealing. So a better demonstrating image was created. You can find this image about endoscopic repair of lateral recess sphenoid sinus CSF leak on the recent issue of cover page of Neurology India. We should not limit our abilities to medicines alone. We can draw the beautiful natural scenes. You can create scene of your imagination. It's okay. There's some problem with the laptop. And you can paint whatever you like. If you are a nature lover, you can pen down the beauty of lovely words and your cute pet. Let the imagination fly. You can land on the moon without Chandrayaan. You can portray your favorite player. Can anyone identify him? But I don't like this calm version of Virat Kohli. I like this Ben Stokes version of Virat Kohli. We just need to step up from I won't do it to I did it. It does not matter how slowly you go, as long as you do not stop. कहते हैं अगर किसी चीज को दिल से चाहो तो पूरी कायनात भी तुम्हें उससे मिलाने में लग जाती है. And if you are still not feeling motivated, then when you are feeling sad and achromatic, life feels empty, and art can cheer you up. Thank you. Thank you for your kindness.
Sanjeev,
sorry, I could not show some photographs.
Sanjeev, this is brilliant work. It's a tremendous work.
Thank you, sir.
So, what's a minimal configuration which one should start with for making a drawing like you? Or could you take a workshop in the next conference to how to
maybe
do a medical illustration?
I am comfortable with that. It is a very easy thing. It is just buy an iPad Pro, pencil stylet is there. This is 799 rupees, one-time download Procreate software. Just watch some YouTube tutorial. You will feel it is easier than to actual drawing on paper.
iPad Pro and styler.
Pardon?
iPad Pro.
iPad Pro.
Yeah.
Thank you, sir.
So now may I call upon my friend, my senior, my philosopher, guide, Dr. J.S. Khatpal sir. It's long-awaited lecture. We are going to hear the connection between the music and the neurology. So, Dr. Khatpal sir.
Thank you, sir. Thank you, everybody, and good evening, everybody. This is a slightly different topic, but it is totally scientific. And I think the music in neurology is gaining more and more strength. दे दिया था ना मेरे पेन रन कर
ये आप ही ने लगाया होगा
नहीं मैंने कुछ नहीं लगाया
आपका पेन ड्राइव
आपको दिया था सुबह
अच्छा मेरे पास था वही है क्या
हाँ लाल वाला छोटा
हाँ नहीं
हाँ यही
मुझे एक्चुअली क्या याद नहीं था ये किसका
म्यूजिक प्ले कर दूँगा फर्स्ट स्लाइड पे भी
हाँ 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 सर ये वाला नहीं होगा सर ये है क्या सर
अब यही रहना हाँ इस पे म्यूजिक लगा
एक मिनट साउंड वाले को बोल साउंड देगा चालू है
फर्स्ट वाला लगा ना, म्यूजिक फर्स्ट वाला
ये फर्स्ट वाला ही तो है
नहीं,
सर।
ये फर्स्ट नहीं है, फर्स्ट वाला जो आपने शुरू में सुबह आपने सुना भी था, मैंने
हाँ सर।
सुनवाया था इसके पहले वाली स्लाइड। हाँ, इस पे
आना तो चाहिए, आके मेरा सर।
इसके पहले वाला। हाँ, इस पे है म्यूजिक है। इसके पहले, हाँ इस पे
आ नहीं रहा है ना सर।
हाँ, तो इसके ऊपर आना चाहिए ना। सुबह तो वो सुनवाया था।
आ नहीं रहा है सर साउंड।
क्यों नहीं आ रहा है?
आगे का है ना?
हाँ, ये करेक्ट।
इसके नेक्स्ट वाला
नहीं, इसी
नहीं सर, इसी में साउंड है।
इसी में साउंड। Sea waves, droops of raining fall over the roof, murmur of trees, strumming of the strings of musical instruments are all music. Music is nature even before existence. This is, I want to clarify you, when Lord Brahma created the universe and when he saw all around that what is happening in the universe, he felt कि कुछ मजा नहीं आ रहा, जो मैंने बनाया पूरा संसार, ये देख के कुछ मजा नहीं आ रहा। I mean, पत्तों की कुछ चमक नहीं है, पानी में कुछ गिलोरियां ठीक से नहीं आवाज आ रही है, कुछ nothing is working out very well. Then he called Saraswati ji and produced Saraswati ji, and when she started string of the music, the whole world changed. The rivers were different, the mountains were different, and all atmosphere was different. Music is meaningless without an appreciative mind. Music is meaningless without an appreciative mind, as I just told you. Your brain on music, music as a distractor focusing on the attention away from the negative stimuli to something which is pleasant and encouraging. Learning to music causes to brain release dopamines and feels good chemicals. Music has also the power to improve your state of mind. This helps keep you in things away from depression in anybody. Music therapy is searched more than 33,000 times a month on Google. The average person listens to 25 songs per day. Music therapy is the clinical, evidence-based use of music interventions to accomplish individualized goals within a therapeutic relationship by a credentialed professional who has completed an approved music therapy program. You can understand the history of music. I just mentioned to you that Saraswati Ma started the music and the whole things went on, the ragas were produced, and the ragas are still very relevant. They are useful in all kinds of diseases, including our psychiatric disorders, insomnia, they are used in chronic pains, and so much else. C.V. Raman at Kolkata pioneered on Indian musical instruments between 1909 and 1935 with several publications including in Nature. Presently, research effort in this direction of music and physics is being superheaded by C.V. Center, Jodhpur University. Some excellent and rigorous research work in the area of music was done by ITC Sangeet Research Academy since 1983. Music is not only a source of enjoyment, entertainment, but a powerful tool of enhancing well-being. It is said that when Lord Krishna played flute, cows used to give a lot of milk. They were supposed to do that. That theory is relevant even today. If you go to any cow places where they are breeding a lot of cows, you will find that the music is playing there, whether it is United States or whether it is in the entire Western world. You can see here, is my music
Para vocês verem essa vaquinha aqui, ó. Pra quem não acreditou, essa é a minha. Ela só desce leite quando eu toco o violão. Vê?
milk which is coming out.
हमने सब तैयारियां पूरी कर रखी है। आज दरबार में हमारी ख्वाहिश पूरी की जाएगी।
अवश्य महाराज, परंतु इसमें अग्नि भी लग सकती है।
वही तो हम भी देखना चाहेंगे।
जो आज्ञा महाराज।
इरशाद।
दीपक कथन दीपक कथन करत राग लक्षण ग्रंथ मेल कमर धनी दीन हस्त जात गत दीपक
The lights will be there. The fire will be there.
दीपक
Burnt with fire, and now there is a music so that the rain is there. The power of music, now let me show you an example. The power of music has infused new life into Monisha. This girl was throttled by her parents and was thrown on the road. Somebody saw her and hospitalized her in Bangalore. She was bedridden after barely escaping being throttled by her parents, who ended their own lives. When she was given the music of her favorite heroes, the movies which she used to see, she gradually started improving, and you can see that the mute kid talked. Music therapy is a science that makes use of the fine art of music for prevention and treatment of various diseases, in addition to ensuring better health. Now, how music affects your brain, you can see that music activates the motor cortex, causing you to tap your foot to the song. Music stimulates emotion from the nucleus accumbens and amygdala and cerebellum. Music is processed in the auditory cortex. Music stimulates memories from hippocampus. Song, lyrics activate Broca's and Wernicke's areas. The parts of our brains that process language are also stimulated by music. Music, though a universal language, needs a precise selection for a particular person on a particular occasion at the specified place. Then only music unveils its marvelous healing properties. First, let me show you the power of music, and then we'll proceed further. Yeah, usme, you know. Yeah, it's there.
मेरो झूम गे आज गावत मन मेरो झूम गे तेरी तान भगवान आज गावत मन मेरो झूम के आज गावत मन मेरो झूम के तेरी तान भगवान आज गावत मन मेरो झूम के हर गया तो जीवन जावे जीता गायक दुनिया पावे रखी जो अब मोरी शान रे आज गावत मन मेरो झूम रे प्रेम के कारण प्रेमी गावे तानु से पात्र जलावे
The stone will get broken with the power of music.
आज गावत मन मेरो झूम के आज गावत मन मेरो
The people are here to watch whether the music can do that or not.
सात सुरों के मधुरा मिलन में जादू आज जगा बैजू के संगीत से दाता जल में आग लगा दे जल में आग लगा दे आज गावत मन मेरो झूम के आज गावत आज गावत आज गावत आज गावत आज गावत मन आज गावत आज गावत मन मेरो झूम के आज गावत मन करे मबा करे बाबा रे हरि करे मबा बाबा रे करे दा करे दा बाबा मबा बाबा रे करे दा आज गावत मन
Now there are two schools of thoughts, which one is little modern and one started some time back, but both improve the qualities and lot of diseases through these musics. One is this Mozart effect and the other new is the entrainment theory by Michael Todd, which started in 1990s. Mozart effect refers to the enhancement of performance or change in neurophysiological activity associated with listening to Mozart's music. The Mozart effect was enhanced performance in special IQ, increased by 8 to 9 points in scores of special temporal reasoning, tested in 36 undergraduate students, increased EEG coherence, increased correction of neurophysiological activities of temporal and left frontal areas, spatial-temporal reasoning after piano lessons in preschoolers, changes in amplitude of alpha rhythm, interhemispheric coherence, changes in power and coherence of EEG, especially in the right temporal areas. Distinctive aspects of the music are that the Mozart music has long-term periodicities that may well resonate within the cerebral cortex and also may be related to coding within the brain. The seizure activity decreases is related to the long-term periodicities. Short-term periodicities does not help the decreasing the seizure activity. why this term Mozart music is being used. There were at least 4 very great musicians at that time in the world: J.C. Bach, J.S. Bach and Chopin and Mozart. But it was observed that the medicinal outcomes were best by Mozart music, and then it was found that Mozart had the capability of turning the key of short periodicities into long periodicities, so that it can change the neo-architecture of the brain. The microanatomy of the brain can change, and then there is a columnar arrangement of the cells which becomes little different, and it produces beneficial effect on the health of the human being. Piano sonata in D major key 448 was played. 29 patients with seizures were examined. Significant decrease in epileptiform activity noted in 23 out of 29 patients. Even in patients with status epilepticus, coma or periodic lateralized epileptiform discharges, effect was either immediate or required 40 to 300 seconds. Change in the ictal activity decreased from 62% before Mozart to 21% during Mozart music. Amplitude also showed a decrease. As I mentioned to you, that Mountcastle first investigated and provided evidence of the impressive neocortical organization. Columns of cells that have the same property of place and modality were noted. Now this is to present you a case which we treated. This is a boy now aged 36 years, Master Nikhilesh Bhandari. He had a neonatal history of Pitocin-induced labor, low birth weight. Mother had PIH treated conservatively. Recurrent seizures were there. First seizure at BCG vaccination, and recurrent febrile seizures were occurring. Patient started having 3 to 4 episodes of seizures. Fixed time pattern at night and day, 3 times at night and 2-3 times in the daytime. MRI brain was normal. EEG showed epileptiform abnormalities. Milestones were delayed. Nutritional therapy advised. No improvement in the child. Diagnosed to have autism at the age of 3 years. This is the child when I saw him for the first time at the age of 3 years at his residence. Special electronic ear used to stimulate with special phonic sounds. Maternal, paternal voices used. Special physiotherapy started. This treatment was devised by the French pediatrician Dr. Alfred Tomatis, who himself was an autistic child. Alfred Tomatis, at that place, when we had taken the child to Paris to show him, he was running 200 centers all over the world for playing this kind of music, and mainly the people who were getting benefit from it was mental retardation, cerebral palsy, chronic seizure disorders, and of course autistic children. This is in Phoenix, which we had taken him for the Phoenix, USA, where he was taken for the music this thing. This is, we had taken him to Mayo Clinic for a further assessment. Child status now is that responds well to calls, stands without support, walks without support, controls head and neck, follows with eyes, toilet trained, able to communicate, asks for food and eats it. This is, you can see the standing child, though this is also a little older photograph. He's further better, let me tell you, in the latest examination. This is how the music can help you all over. Aphasia, dyslexia, related speech motor impairments, autism spectrum disorders, dementia and learning memory deficits, Parkinson's disease and stroke. And of course, let me add to it, traumatic brain injury. They are also equally helped with music therapy. Songs can take us to places we cannot get to ourselves. When we identify our favorite songs, we get a glimpse into our own soul. For patients suffering from Parkinson's disease, it gives them rhythm, tempo, and organized time. I'll take 1 minute here to explain you that this is the theory of entrainment on which right now all the centers are working. It's very simple. If you have a pendular clock in a room, and if you put another clock, the same pendular clock in the room, after a few hours, after a day, you will find that both the clocks are moving at the same speed, same pace, same everything. This is called the theory of entrainment. And on this, the treatment of Parkinsonism, stroke, and traumatic brain injury becomes very simple because the cadence is made, the steps become better. This I mentioned to you that the Michael taught is producing this rhythmic auditory stimulation theory on which in many centers in the world this treatment is going on right now, and there is a lot of work which is going on this treatment. Now you see this, the step upwards and the step downwards. After the music therapy, the stride length is better, their steps are better, their gait is much, much better. This is a center where this steps and all this is going on with music. All this dance, etc. is going on with music. This is your brain on drugs. This is your brain on music. So the things which can be taken care of, I told you already: traumatic brain injury, stress, dementia, autism, movement disorders. Music emerging as a means to manage chronic pain. Common clinical experience is that music interventions or music therapy are only rarely included in pain treatment plans and offered mostly for patients in pediatric neurology units. Today we have some articles, not only from outside but from our own country, where they have proved that 50% of the drug requirement was reduced after giving music therapy to people who had undergone major surgeries. So music is the best, cheapest, mind-alerting drug in the world. And since the future is going to be not only music therapy, but also music and dance therapy, so we'll end with it.
हीरो से भी तेज कोई कर सके जो बेद नाचो अस्तबल में घोड़े जैसे पाक डोर छोड़ नाचो मिट्टी जो रोट मोटा मिर्च खा के ऐसे नाचो हाँ जा छोरे हाँ जा गोरे हाँ जा छोरे नाचो 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 वीर नाचो
If the hall was full, then we would have asked everybody to dance around.
नाचो 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 कच्ची कैरी जैसा खट्टा नाचो 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 बिच्छू काटा लागे ऐसा नाचो
Thank you.
बैल जैसे धूल उड़ा के सींग उठा के तुम भी नाचो
Thank you.
So thank you, Dr. Katpal. It's very interesting, and there's a lots of knowledge here. And the session is open up for the question and answer. Any queries? Human? Where is HP gone? Left. So anyone, any question? So thank you, sir. Thank you very much. We appreciate. And now it's a time for a poetry in a neurology. And it's Dr. Avek Bandhari who is going to talk about it. Human, any insight into music and this thing, neurology? Any thought? Give him a mic. Pass a mic to Dr. Bhoi.
See, that is only one scientific example which I showed you, that in which Mozart music was studied very heavily by the Harvard University people. The Harvard University is still doing research work on the Mozart's music, but today this is also very clear that for many conditions like insomnia, like for depression, like for anxiety, like for psychosis, regular music which a patient likes is good enough. Except that you have to take only a slight care that if somebody is depressed, you cannot be playing a very gloomy song to him. At least play a song to him which makes him happy. That is very important to know. Otherwise, music of their own choice helps in many diseases. But certain musics have been studied in detail, and Mozart in particular was studied very extensively, and still some experiments are going on. Because as I told you, where Mozart was living and where his school was, both have been converted into research laboratories, and Harvard is taking care of that, and regular work is going on there. Just 1 second more. In the similar way about Mozart which we talked, ragas are doing the same thing, sir. There are distinct ragas for different diseases. And there are some ragas which take care of pain, there are some ragas which take care of your mood, there are some ragas which take care of other diseases. There are some ragas which take care of headaches. There are some ragas which take care of epilepsy. There are some ragas which take care of stroke. I mean, all this is mentioned in the literature.
Yes, there is a lot of a correlation between a positive finding with the music, especially happiness, and localization towards the right side of the brain. So these 3-4 things are clear. What's not very clear to us is why some kind of a music makes you weep. So certain music you listen to a certain kind of a notes and you start weeping, or there is at least a lacrimation. So why this is there, and what's the relation of amygdala and temporal? This circuit is not that much clear.
Sir, they are still under process of research. But on the face of it, you ask me, it produces certain emotional changes in the mind which makes it do that.
Yeah.
But things are under research.
Yeah.
Unfortunately, Indian ragas which are so strong theoretically, we haven't taken up them for research at all.
And then once you recover from aphasia, music is something which is first to recover. You recover your bhajanas, Guru Shabd and this thing.
If you teach some patient with aphasia, the first thing which he will start will be singing. He may not be able to take out the entire words or vocabulary, but singing he will start the first.
So I am surprised by the story of Bade Ghulam Ali Khan.
Yeah.
He suffered from a right hemiplegia and aphasia, and his motor deficit remains there. He recovered from his speech deficit and he started singing again.
Absolutely.
That's the story of Bade Ghulam Ali.
Yeah. Sir, the musicians have a different kind of brain. That is also almost very clear now, that the musician's brain is slightly different from a regular person's brain. For example, if you want to learn about absolute pitch, then there are only 2 things which can make you do that. Either it is by God's grace. Some people who are born with it, that they have a quality of absolute pitch. Otherwise, you can develop an absolute pitch only if you have musical teaching between the age of 7 to 11 years. Otherwise, you will not be able to pick up that.
So I think the term riyaj has lots of things to do with it. So they keep on repeating, they do riyaz day in and day out, and that's why their circuit become very strong and they are able to recover fast.
Fine. Yeah.
So Avik, we are waiting for you.
What a wonderful experience to hear music and neurology from Dr. Katpal sir, and equally a great opportunity to speak after him. मैं यहाँ इस लहराती हुई वेशभूषा में आ रहा था, उधर कोने में बैठे ऑर्गेनाइजिंग चेयरमैन का सर चकरा रहा था। वो बोले, ये क्या वस्त्र है डाला, ये तो है वैज्ञानिक अखाड़ा। मैं मुस्कुराया, उनको कोने के भी कोने में लाया, फिर फरमाया, संजय सर, माल कैसा भी हो, माल कैसा भी हो, बिकना जरूरी है। अगर कवि जैसा लिख ना सकूं तो कोई गिला नहीं, कवि जैसा दिखना जरूरी है। For the next 10 or 15 minutes, whatever I am given by the chair.
Just excuse me for a minute. Sir,
You are
don't you
always
think that we are dealing with a different brain?
Thank you for the adulation. For the next 10 to 15 minutes, whatever the chair gives me, I would like to focus, I would like to have your focus away from the slide. I am a 5 foot 10 inch slide in front of you and everything will be done here. So, I would like to take you on a journey. It's a journey which we all practicing doctors have gone through. It comes into the clinical practice and experience of each one of us. The journey of a patient coming to us in a critical condition and getting admitted under us, and then how the events unfold and the magic and the drama begins. I call it the patient saga or Mari's Gatha. So how I put it is, there is a word in Hindi called marnasan. Marnasan means in a condition of near death. So that is how I put it. वो लाए थे मरणासन, वो लाए थे मरणासन अपने पिता को, बचा लो जान बस इतनी विनती है। वो लाए थे मरणासन अपने पिता को, हे डॉक्टर बचा लो जान बस इतनी विनती है। अल्लाह राम ईश्वर रहीम सब कुछ आप ही हो, पूजनीय वंदनीय आदरणीय में बस आपकी ही गिनती है। जो जो इलाज शुरू हुआ, जो ही मरीज का इलाज शुरू हुआ, रिश्तेदारों के पर निकलने लगे। वो जो मीठी कोयलें थी पहले, वो जो मीठी कोयलें थी पहले, अब कर्कश कौवे बनकर मुझ पर बिफरने लगे। दूसरे ही दिन मरीज ने आंखें खोल ली, दूसरे ही दिन मरीज ने आंखें खोल ली तो उसका भाई बोला, अजी डॉक्टर ये बोल क्यों नहीं पा रहे हैं? क्या आपकी दवाइयों का साइड इफेक्ट है जो इस हालत में नजर आ रहे हैं? पांचवें दिन मरीज चलने लगा। We had given music therapy also, so पांचवें दिन मरीज चलने लगा तो उसकी पत्नी बोली, अजी डॉक्टर देखो थोड़ा लड़खड़ा रहे हैं। सातवें दिन मरीज बोलने लगा तो उसके चचा बोले, आवाज में वो खनक नहीं है। आठवें दिन मियाँ सरपट भागने लगा तो उसके बचपन का यार बोला, कदमों में वो धमक नहीं है। जब छुट्टी करके बिल चुकाने की बारी आई, जब बिल चुकाने की बारी आई तो रिश्तेदार साफ मुकर गए। बोले, जब हमारे मरीज को कुछ फायदा ही नहीं हुआ तो हम किस बात के पैसे चुकाएंगे? So this is how the journey continues. We often see a lot of back pain patients in the OPD, and I would like to tell you that back pain is the most leading cause of morbidity in the world. It is seconded only by headache in the cases of highest number of work absenteeism. Maximum people take leave from office for back pains. And this is the conversation between a patient of back pain and myself, and how he narrates the agony, the disturbance the pain is causing in his life. He says, ये दर्द मुझे बेदर्द बना देता है, ये दर्द मुझे बेदर्द बना देता है, ज़मीं और आसमां के फासले मिटा देता है, कभी कमर, कभी पैर, कभी कुल्हा, ये मेरे घर का चूल्हा बुझा देता है. So because he cannot go to the work and his income suffers, and it causes a lot of economic depreciation also. And now what I respond to him is, कमर से आगे झुकना मना है. सुनो, कमर से आगे झुकना मना है, जमीन पर नीचे बैठना और नीचे बैठकर उठना मना है. कमर रहे हरदम सीधी आवेग, न्यूरो सर्जन के दर पर फटकना मना है. Fortunately, there are no neurosurgeons in the hall. Oh, you are there. So you are our guest. You will pardon us. कमर रहे हरदम सीधी आवेग, न्यूरो सर्जन के दर पर फटकना मना है. तू निडर है, तू वीर है, सरपट चलता जा, भय और संशय से रुकना मना है. So fear is the worst prognostic factor in case of back pain. Those patients who have more fear have the worst prognosis, irrespective of the etiology. Now, I would like to take you on to another journey. एक दूसरे सफ़र पे चलते हैं कि वो सफ़र है जो उससे हम सभी गुजरते हैं. The ascent of a doctor. When we start our practice and then when we start growing our stature as a doctor, as a practitioner, then how the things around us change. I call it, अब हम बड़े डॉक्टर कहलाते हैं. पहले जब मैं छोटा डॉक्टर था तब मैं फेशियल पाल्सी के मरीज को भी रात को 3 बजे अस्पताल देखने चले जाता था. विजिटिंग फीस की उकेरी गई न्यूनतम मुद्रा का लिफाफा भी कई बार मुझ तक नहीं पहुंच पाता था. अब मैं बड़ा डॉक्टर कहलाता हूं. आकस्मिक लकवे को देखने भी 2 दिन बाद जाता हूं. नकद मुद्रा का लिफाफा काउंटर से हाथ में लेकर ही आईसीयू में तशरीफ ले जाता हूं. अब मैं बड़ा डॉक्टर कहलाता हूं. पहले मरीज मुझसे सीधे बतियाते थे. अपने सुख दुख का हाल गा गा कर मुझे सुनाते थे. पहले मरीज सीधे बतियाते थे, अपने सुख दुख का हाल गा गा कर मुझे सुनाते थे. अब मैं सिर्फ अपनी बात कहता हूं. सुनने से कतराता हूं. अब खुली वार्ता का कोई विकल्प नहीं. अब मैं बड़ा डॉक्टर कहलाता हूं. पहले कर्मचारियों से, बाइयों से बतियाता था. कई बार उनके साथ बैठकर खाना भी खाता था. अब हम बड़े डॉक्टर कहलाते हैं. हो जाता है सन्नाटा जहां से निकल जाते हैं. अब हम बड़े डॉक्टर कहलाते हैं. पहले पड़ोस की आंटी को देखने उनके घर चले जाता था. मुफ्त की सैंपल की दवाइयां भी उन्हें थमा आता था. अब परामर्श के लिए हम उन्हें क्लिनिक बुलाते हैं. रिसेप्शन पर फीस जमा होने के बाद ही उनकी फाइल बनाते हैं. अब हम बड़े डॉक्टर कहलाते हैं. बिक जाता था पहले एक छोटी सी मुस्कान पर. अब हम हीरे जवाहरातों, जमीनों, जायदादों में तोले जाते हैं. अब हम बड़े डॉक्टर कहलाते हैं. न जाने कब कैसे ये हश्र हुआ. रगों में पानी ज्यादा और खून कम हो गया. वक्त की रेत हाथों से फिसलती रही. मैं फरिश्ता था पहले, अब यम हो गया. So this is how the journey continues, and what the fear behind it is. मुझे चीन पाकिस्तान का भय नहीं, मुझे चीन पाकिस्तान का भय नहीं, ना ही विश्व युद्ध का भय मुझे सताता है। बस एक ही डर है मेरे अंतस में जो मेरी आत्मा को कंपाता है, कहीं भारत की सरजमी पर ऐसा दिन ना आ जाए, कहीं भारत की सरजमी पर ऐसा दिन ना आ जाए कि सारे छोटे डॉक्टर नदारद हों, कहीं हम सारे बड़े डॉक्टर ना हो जाएं। So we have to be really careful in when we grow our stature as a clinician, and that is my own experience. I don't know if it matches with your experience of the audience, but there are things which we have to take care of. It has been a wonderful conference with the support of an excellent organizing committee, and you will recognize the names of few people of the committee in the coming lines. It's not working, it's not needed actually. इरादे हो हमारे गगनचुंबी. Dr. Gagandeep was here, I suppose, for the oration. इरादे हो हमारे गगनचुंबी, संजीवनी सा व्यवहार रहे, संजय सी दूरदृष्टि हो हमारी. You all must be remembering Sanjay from Mahabharata, who used to tell what is going on at the war field from miles away. संजय सी दूरदृष्टि हो हमारी, मधरिया सा जोश बरकरार रहे, देव व्रत से गूंजे ये पृथ्वी, प्रकृति की अनुकंपा लगातार रहे. धन्यवाद. थैंक यू.
I think it's a most wonderful and most satisfying session after a day-long science. May I conclude this session now, or?
I think this session can also invite questions. If there are any, I would be happy to answer.
Anyone about poetry and neurology?
ये चलाओ ना slide.
मैं कुछ दिन पहले एक छोटी सी लाइनें पढ़ रहा था, 2 लाइनें मेरे को काफ़ी अच्छी लगी. वो उसने लिखा था कि अस्थमा के रोगी सा कांपता हुआ, अस्थमा के रोगी सा कांपता हुआ, सूरज ढल जाता है खांसता हुआ. अस्थमा के रोगी सा कांपता हुआ, सूरज ढल जाता है खांसता हुआ. बस यही 2 लाइन याद रही. कविता तो काफ़ी अच्छी थी. So let's conclude now.
I also would like to invite all of you to my session at the Indian Academy of Neurology conference in Madurai. We'll be doing a 1-hour session on poetry in neurology, and the most important part why I am announcing it here is that out of that 1 hour, other than my presentation, we'll have a poetry quiz. Also, we'll have an open mic session. So whoever wants to share his creative ideas in English or Hindi on the dais, please, you can please forward your names to me, and we'll like to include you. Also, I'll be presenting my work on poetry and neurology in the upcoming World Congress at Montreal, Canada. Thank you. Thank you. Thanks a lot.
Now I will request the chairperson to felicitate the speaker, Dr. J.S. Khatpal sir, Dr. Avek sir, Now, I would like the speaker to give away the memento to the chairperson.
Hello. So at 5:30 p.m. there is
Hello.
a general body meeting. General body meeting is going to be held at B Hall B. And then 7 o'clock there is inauguration and followed by a gala dinner. So that's the plan like. Thank you.